ம். சரி
யூடியூப் போனா நம்மளோட போர்ட்லாம் இந்த பிளேன்ல பிளே
இது கேமராவா வந்து நீங்க வந்து இப்போ கொஞ்சம் சார் போட்டுருக்கேன் என்ன சார் டவுன்லோட் பண்ணும் சார்
இது வந்து வீடியோ
ஹை I'll paste it. Sir.
நேற்று தான் ஓகே வாங்க இன்னைக்கு நான் ஜிஹெச் வந்துருக்கேன்.
This is only PPT, sir. Coming. ஆமா சார் சேம் ஃபைல் போட்டோம் சார் அதையும் காப்பி
This talk, please. This talk will not same way.
Yeah, the other side downwards.
ஓகே ஓகே அப்ப ஷேர் ஸ்கிரீன் போட்டு சாரோட ஃபர்ஸ்ட் ஸ்லைடு போட்டு
ஸ்லைடு இன்விடேஷன் போட்டு yeah video
செங்கல்
லிங்க் அத கிரியேட் இது மீட்டிங் ஸ்டார்ட் பண்ணும்போது
என்ன சார் பண்ணு ஜூம் போயிட்டு
இன்விடேஷன் அதோ இதுல தான இருக்கீங்க ஸ்கிரீன் இது இப்போ பாருங்க இல்ல இப்போ நீங்க ஜூம்ல போயிட்டு அதுல ஷேர்
ஜூம் போயிட்டு
ஓபன் பண்ணுங்க வந்து ஷேர் ஸ்கிரீன் அப்படியே ஓபன் ஆயிடுச்சு ஆல்ரெடி ஷேர் ஸ்கிரீன்
ஷேர் ஸ்கிரீன் தான் இருக்கு
ரிட்டர்ன் டு மீட்டிங்ல தான் போடுங்க ரிட்டர்ன் டு மீட்டிங் இப்போ போங்க ஷேர்
ஓகே ஷேர்
அன்பு
ஓகே இருக்கு ஆன் பண்ணி
இந்த டிவியை மட்டும்
அங்க டிவி ஒன்று இருக்கு
ரெண்டு தேவை சார் பேட்டரி
டெக்கி டீம் வந்து ஆர்ஆர் நெக்ஸ்ட் கேஸ்ட் வந்துச்சு சார் லைவ் வந்துச்சு
சார்
சாருங்க வால்யூம் பண்ணி சார் அதான் சார் வால்யூம்
எல்லாமே கொடுத்துருக்காங்க
என்ன பண்ணுவீங்க சார்
இல்ல நம்ம டெலீட் பண்ணிடலாம்
இது ஆன் பண்ணி விடுங்க.
நல்லா இருக்கா? நீங்க ஒரு வெல்கம் இதுல ஒரு இதை ஓப்பன் பண்ணி வச்சிருக்கீங்க. வால்யூம் கம்மி பண்ணி அந்த வால்யூம் கம்மி பண்ணுங்க சார். இதுல வேற ஏதாவது
எதுவுமே இல்லை
சேனல்
இல்லையே.
லைவ் ஸ்ட்ரீம் ஓகே. இந்த ஓகே இல்ல
இல்ல
இதுல
அந்த வரல பாருங்க. அதுல ஆன் பண்ணுப்பா.
வந்து அந்த
இது வருது.
வெளியே presentation open up.
எல்லாம் ரெடி சார், எல்லாம் ரெடி. Pediatric urologist. Apollo sir. Our friend. Panelist.
Pediatric. Peter,
a very good morning and welcome you all for this prestigious program in CME and Pediatric Urology. Why is this prestigious? Why is this prestigious? It's because we have once again gotten an opportunity to get in all our professors, our retired professors. We know how knowledgeable they are, and all our senior people to come here and share their knowledge with us. And why this is important is because now we have got faculty from pediatric surgery who can give a lot of input to us. We thought it will be extremely useful to many urologists when pediatric surgeons come here and give their inputs. And more importantly, one Professor J.V.S. Prakash, who has served the Institute of Urology as well as the Department of Stanley Medical College for nearly 17 to 18 years in service, is retiring today. Today means in a week's time. So we have to commemorate the superannuation of him. And we thought this will be a much better function to commemorate the superannuation of Professor J.V.S. Prakash. So thank you very much for everybody to come here. And Prakash sir is already here. Thank you very much, Prakash sir. It is based on you that we have started the superannuation program, and based on you that we have started the CME. Thank you very much, sir. And may we call the first speaker on stage, Dr. Radhakrishnan, to kindly take over the stage, please. Just to some of speakers, the sessions are for 1 hour. The speaker will be speaking for 15 to 20 minutes in their session, followed by panel discussions. The panel discussions will have 4 people, 1 pediatric surgeon and 3 urologists in the panel for discussion. And at 45 minutes, there will be 1 short bell. At 50 minutes, there will be 1 second short bell. And when the time is over, there will be 1 long bell. Thank you very much.
Thank you very much, Dr. Chingal Ryan. Thank you. Most people over here, other than 3 of them, probably don't need. Oh, and here's a man. We are buddies from first standard to 10th. Yeah. So, Dr. Prakash, congratulations on your superannuation. Best of luck. And without much ado, and Dr. Chandrabaran, don't worry about bells and all. My bell and whistle is all long gone. Okay, I won't reach 45 minutes. Okay. Right. So, for those of you who don't know me, my background is till 10th. I was here with him in Kendriya Vidyalaya, right from CLRI to IIT, and then I left for Kerala. Did my MBBS there, went to the army, served in the army. I was not sure I wanted to be a doctor. Anyway, and then I moved to the US, did my general surgery and pediatric surgery there. So I don't do a whole bunch of pediatric urology. So when Shiva called me and asked me, can you talk about something in pediatric urology? I said, hey, I don't do pediatric urology. I said, but you do tumors. You can talk on pediatric. I said, all right, fine, we'll do that. And I came back for good in 2017. I was here for a couple of years before that. And now I'm here. I'm a Chennai 8 Malayali, everything you want. Okay, so let's start. How do I move? Just press the down button. Yeah, okay. So, thing moving. Oh, I guess I have to click on this here. So I have no disclosures. The only disclosure I have is I don't put you to sleep like my dog. Okay, my dog, I don't bore you to death. Okay. So pediatric renal tumors, most of us see Wilms tumor most of the times. Once in a while, we'll see a RCC in an older kid or a rhabdoid tumor, and very unusually anything else. So of the tumors we see, about 10 to 15% of them will be, to me, for my numbers, 10 to 15% is too much. I have done more Wilms than I've done the other tumors. In my case, maybe 5 to 10% would be non-Wilms tumors. And pretty much the guiding principle of treatment is same in most of the renal tumors. This is, I know it's a busy slide. I know it's a very tiny font, but what do we see? We generally see Wilms tumors, renal cell carcinomas, rhabdoid tumor of the kidney, CCSK, clear cell sarcomas, congenital mesoblasthic nephromas, cystic nephromas. Then in RCC, we rarely sometimes see variants of RCCs. So it's too much to go through such a slide. So let's start with what we guys know a little better. It's Wilms tumors. Majority of them are non-syndromic Wilms. About 10 to 15% are associated with other syndromes, and 1 to 2% about familial, and 5 to 10% bilateral. Now, I will not be going into all of you are urologists and trained urologists, so there's not a whole deal that I can tell you guys about what a kidney is and what these tumors are, but I'll go through some of the basics though. So it's interesting, the genetics of a Wilms tumor is quite interesting. Chromosome 11, poor thing, gets beaten up all over the place. If you look at our surgical oncology, this chromosome level pops up in so many places, okay? And sure enough, in Wilms tumor too, similarly, P53, another thing that gets beat up all over the place. Anyway, so we have WT1 gene and a W2 gene, but WT1, Wilms tumor 1 gene, is on chromosome 11, and it's important for the regular development of the kidney, okay, for the urethral buds and all of that stuff. Then you have P53 translocations, okay, and most of them, when you have that, when you identify them, a great variety of them are involved in anaplastic Wilms tumors. Then the other things like NMEC and gain of 1Q, all of that is there. And the loss of heterozygosity, which unfortunately here we are not looking at because I don't know about Ramchandra. We guys go by COP protocol, and in COP, once you treat the kidney with chemo, then it alters the thing, and you will not be the histology, and you'll not be able to look at loss of heterozygosity. These loss of at 1P and 16Q are associated with relapse and increased incidence of treatment failures. So I guess there are not a whole bunch of PGs here, so maybe I should just skip this question. Oh, except the front row, huh? Okay. All right. You look young, yeah, I know. Yeah. So the PGs, can you guess? These are syndromes associated with Wilms, the first one. Anybody? Yeah, what is it associated? Oh, Vega, yeah, okay. Second one? I myself don't know. The third one is quite easy, right? The second one is just pure hemihypertrophy, and the third one is Beckwith-Wiedemann. So all this, I don't need to go through, you guys know it. So what you need to know is, in syndromic Wilms, okay, we categorize as them as babies with syndromes who are at a high risk to develop a Wilms tumor, who are at intermediate risk and at low risk. So high risks obviously are, do I need that? Those with Vega and Denny's trash. Then moderate risks, Beckwith-Wiedemann, Frazier. Low risk, Bloom, Dicer-1 syndromes, pleuropulmonary blastoma, that comes. Leaf-Romani. I was surprised when I read Leaf-Romani is on the lower side. I would have thought it was going to be on the high risk. And isolated hemihypertrophy. So imaging, this is in Wilms tumor, okay? Maybe I should have got to how they present first. Let's see if I have it. Staging, most of you, all of you know this. I don't have to go through it specifically, except, we have a stage 5, which is a bilateral Wilms, and the others are all pretty much standard. Now, what is the difference in treatment, COG versus PSYOP protocols? COG advocates for upfront nephrectomy, whereas PSYOP, except for babies under 6 months of age, advocates for neoadjuvant chemotherapy followed by resection in all cases. So there are advantages and disadvantages. The advantages in the COG protocol is that, well, you have a complete histology of the tumor. In PSYOP protocol, especially in India, after coming back to India, what I notice is the tumor size that we see here are much, much huger than the ones that I've seen in the West. In the West, they're much smaller, they come much earlier. Maybe that's why their outcomes, they can claim to be better. And like in COG, the only reason that you wouldn't operate upfront is generally when it's either metastatic disease or you have a tumor thrombus. Even tumor thrombus up to the hepatic veins, those guys operate upfront. Here we don't. And my experience after having come here, SIOP certainly helps in downsizing the tumor burden. It may not bring it down huge because the tumor burden may be less, the size may still be big, but some of the planes are better, easier to visualize. And that's my personal feeling. And there are various chemotherapy regimens, but what I would recommend and I would state is we as surgeons not put too much hand into it. We should know what chemotherapy we are giving. And we in our institute let our pediatric oncologists take care of it. And we go with a 2-drug or 3-drug regimen, vincristine, dacnomycin, and doxo. So treatment, all of us know, surgery upfront or post NACT, followed by either adjuvant chemotherapy and radiotherapy. It shouldn't read whole body radiation. I'm sorry, it should have read whole abdominal radiation, not whole body radiation. Radiotherapy is used in when you either have a tumor spill, you haven't done a lymph node dissection, and so by default you upstage it to stage 3, and any stage 3 disease, and for generalized spill you do whole abdominal radiation. Then there is a role for radiation in treating the lung mets. Those are the common indication. Mets in the liver, extremely rare. Madhu or Prakash, maybe you guys have seen, I've seen only one with a met in the liver. And you don't generally go after the met unless it is a peripheral met and you just can wedge it out. You don't do segmental resections or anything for mets in Wilms tumor. So this is basic chemotherapy regimens. We hardly look for LOH at 1 and 16. So this is mostly adapted from the COG protocols. So if there is one thing that I want the postgraduates to take away from here is that, no matter what you do when you do a Wilms tumor, firstly, send the Wilms tumors to us. You guys don't do it. That would be my thing. Secondly, if you're doing it, never miss out on doing a lymph node dissection. You cannot say, oh, on the CT, there was no lymph nodes. So, or clinically, they look normal, right? You'll be surprised, okay? The commonest problem that we see is when patients have been treated elsewhere and they have recurrent disease, and when you look at the notes, they have received inadequate therapy, I should say, okay, because the nodes were not sampled. And node sampling, I don't know how many of you know Sajid Qureshi from Tata Memorial. He's written a fantastic paper about 6-7 years back in Journal of Pediatric Surgery that describes the nodal basins that you have to address. You have to be on the hilum. You have to take the supra and infrahilar nodes. Then you have to take the aortic nodes, para-aortic nodes in aortocaval window, paracaval nodes, and any other nodes. And it's not a lymph node dissection you do. It has to be at a minimum a lymph node sampling. All right. You have to do that. And you need, according to Sajid's paper, 7, but some of them say 5 nodes but more the merrier. It's not very hard to do it when you have an open belly. So that's the one and most important thing that I would want all of you to take home at the end of this 1 hour. Then tumor thrombus. There are various descriptions of tumor thrombus and various classifications, Ahmad's, Mohammad's, whatever classification you want. But at a bottom line, just imagine it this way. Tumor thrombus going up to the hepatic veins, between the hepatic veins and the diaphragm, and above the diaphragm. In whichever protocol it is, above the hepatic veins, they get neoadjuvant chemotherapy. And what is surprising or what is good about Wilms tumors, Wilms tumor is a very chemosensitive tumor. So even the tumor thrombus regresses more often than not. All right. There are still patients who will have a bad histology and whom it may not regress, but yet you still try it. Oh, before I get to this, so imaging is, I just have a question for the general audience, all right? How many of you do a PET CT? Okay, once you establish a diagnosis of Wilms tumor, let's say it's a right-sided Wilms tumor. How many of you do for metastatic workup PET CT? Is it required or not? I know many of us do it, but it's actually not needed. Okay. When I was training, it was just abdominal CT and just a chest X-ray. That's what it used to be. Then it became abdominal CT and a HRCT chest is all that is required. But when you have gadgets, we seem to use it even when it's not indicated. So PET CT is expensive and you have to keep the baby hungry. They don't get anything in the morning of the PET CT. You need anesthesia, sedation, everything. So you can't have them moving around. So I generally try to tell, but the tumor board generally railroads me and we get PET CTs. Now, this is your area of expertise, renal cell carcinomas. Most of them in children occur in an older age group. And the commonest presenting symptom is, as all of you know, hematuria. Sometimes they may have pain, sometimes mass. Very seldom do we feel a mass. Most often they come as hematuria. I've never had a patient coming with a large palpable mass with renal cell carcinoma. By the time the child reaches 15 years of age, the Wilms tumor and RCC incidence is pretty much the same. Pediatric RCC seem to be a different entity from the adult RCC. You know, you guys see a papillary and what is the other one? Clear cell variants. Most of ours, when we look at them, at least I would say about 40% of the histology is heterogeneous. You can't say, you can't classify it as clear cell or papillary. Most of them are heterogeneous, right? So it's a different, somehow it's a different entity. Then there are some translocations are more common in kids. About 50% of our kids, I think it's chromosome 3 translocations happen. Okay, and that's why they're also, I wrote translational carcinoma, they're translocational carcinomas. And is there a significance of nodal disease in renal cell cancers? In children, it doesn't matter. Okay, if you have, like in an adult, if I'm not mistaken, correct me, if you have RCC with nodal disease, your 5-year survival comes down from 80 to whatever, 30 or 40%, right? But in children, we still have a 5-year survival despite nodal disease of 70 to 80%. So that is something which is different. And all of us know that renal cell carcinomas are not friendly to the oncologists and radiation therapists. So we all go for a Bart Parker-Graham, just use a knife, treat it, or now maybe minimally invasive. And VHL, another RCC with its associations. VHL is von Hippel-Lindau, and all of us know it is one of those terrible diseases to have. It can have renal tumors, pheochromocytomas, neural tumors, weird lymphangiopericytomas. You can have all kinds of tumors with that. And then what is important is sickling hemoglobinopathies. They cause something called a renal medullary carcinoma. I don't know how many of you have seen. I've seen one. You operate on them, they're dead within 3-4 months. I've seen only one. Okay. Then hereditary leiomyomatosis. This is very, I don't know if we see it here, but in the Ashkenazi Jews, they have this fumarate hydratase deficiency, and some of them can have it. And what is important is, if we ever have Ashkenazi over here, you should start screening ultrasounds right from 5 years of age and screening ultrasounds every 6 months. This may just be of academic interest, but where I practiced, we had a lot of Ashkenazi Jews, and this was common over there. I mean, not that the tumor was common, but screening them was common if they had the FH deficiency. My partner and director at the institute where I practice, he had fumarate hydratase deficiency. Last but not least, the association is with treating neuroblastomas with radiation, treating any other abdominal site with radiation can cause RCCs. So a very simple thing, part of your staging, just if I have to tell you something about pediatric RCCs, just remember this much. Patients with lymph node N1 disease, regardless of primary tumor size, are all stage 3. And even if Gerota's fascia is breached and there's a distant met, they're all stage 4 disease. Does up to stage 3 matter in children? Not really, because the outcomes are pretty good. This is all we went. Okay, while imaging, let's say you have a 6-year-old girl or 7-year-old girl, rare scenario, with a left-sided mass, and when you see it, you see some calcification in it. Your antennas need to go up, because is this going to be an RCC or is this going to be a Wilms tumor? It's in that gray area. Okay, that is one place. I didn't get into that on Wilms tumors, but that's one gray area where we would certainly do a true cut biopsy to identify the histology of the tumor. In general, if the clinical presentation is good and fits with a Wilms tumor, we do not do. I'm sure you guys don't do in Ramchandra, right? Do you do a true cut biopsy of all Wilms tumors? We don't, yeah. But there are some groups in India itself who do it on every single patient. But if you look at the protocols, it's not warranted. About 10 years back, we all said that upstage it automatically to stage 3 disease. Treatment, surgery, and then now you have interleukin-2 and ILF alpha, interferon alpha for, I'm not sure if you guys are using it. This is just my reading of it for recurrent or refractory or relapse disease where you can use it. And you can use ALK inhibitors when you have a TFE3 positive on IHC, but without a translocation. A non-translocation TFE3 positive RCC, you can try ALK inhibitors. These are all still investigation. I'm not sure if you guys are using any of this over here. I don't know if we are using it in Srivatsan, you would know. Are we using it for adults? IL-2 or IL-2 inhibitors, no, ALK inhibitors. Now you're using mTOR inhibitors. Only the targeted therapy. Yeah. In kids, we are not using it because we wait for you guys to tell us whether it's safe or not. Right. Now, this is the last tumor that I operated was a rhabdoid tumor of the kidney. It's extremely rare, about 2% in the pediatric age group. They're extremely aggressive, very poor outcomes. Even with localized disease, your 5-year survival is maybe 30–40%. And the weird thing is it can be associated with tumors in other locations, especially the brain. Rhabdoid tumors most commonly occur in the brain, but if they're not in the brain, the commonest site, apart from head and neck, is the kidney. And they have uniformly poor survival. And there are predisposition syndromes, SMARCB1. Okay, what is SMARCB1 with INI, a loss of INI? It's diagnostic of a rhabdoid tumor of the kidney. Now, this I just put up because it's just too much for me and I don't understand the entire thing, but you guys can read it, okay? When I was reading about it, since I still have the patient in-house, I was just looking to see what I can offer them better. This is something I came up with. Actually, St. Jude's for Prakash and Murthy. Yeah, St. Jude's is accepting patients with all things in relapsed rhabdoid tumors of the kidney, provided they'll pay for most of the treatment, but accommodation and stuff of that kind we have to take care of, which most of our patients will not be able to do. So generally younger, average age is about 7 to 8 months, painless mass. Rarely they may have constitutional symptoms, unable to explain why it happens. Maybe the mass itself causing some discomfort to the baby. Quite often it's a post-op diagnosis. At least in my case, 2 of them, when I went with upfront surgery, I thought 9-month-old baby, okay, oh, it's got to be a Wilms tumor. Ended up being a rhabdoid tumor in 2 cases. And they have extreme, even if you think it's a Wilms tumor and you give upfront PSYOP protocol and you start with them with chemotherapy, their response to chemo is extremely poor. So then you face this thing of, oh, no, it's not responding after 4 weeks on your interval imaging. What do you do? So there was one case which we went ahead and biopsied to look what it was. And it still said Wilms tumor. So we continued for another 2 more weeks and then went for surgery, and lo and behold, it was a rhabdoid tumor of the kidney. So this is, I'll get to this in a bit. The timing of surgery, AREN 0321, which is the biggest one for all soft tissue sarcomas, upfront surgery when feasible. If it's not feasible, technically feasible, you have had a true cut biopsy that tells you it's a rhabdoid tumor of the kidney, then you give VAC-based chemotherapy, it's generally VAC-IE, or one of those variants, and then at 7th week or 13th week, you re-image, and depending on feasibility, there's no point waiting past 3 months on them with neoadjuvant therapy. You have to resect all active disease. If mets are present, the treatment strategy is same as Wilms. I'll get to the Wilms mets in a bit. The outcomes are universally poor. There are 2 things that are extremely bad. One is age less than 1 year and advanced disease. Even without advanced disease, you have only 5-year survival of 40 to 50%. When you have advanced disease, it comes down to 11%. Median time of relapse after surgery is 6, after treatment, completion of treatment, not surgery, is 6 to 8 months. Because the relapse is much more early, we need to, their follow-ups, unlike Wilms tumor or RCC, needs to be much more frequent. We actually call them back for monthly ultrasounds. Now, can I have the panelists here? So we'll talk about Prakash.
Thank you very much for the wonderful presentation, sir. Now, may I request the panelists to kindly be on stage, please. Professor R. Jayaraman. May I welcome Professor R. Jayaraman, please. Professor, can you kindly welcome Professor R. Jayaraman onto the stage, please? May I request Professor P. Periaswamy to kindly be on the stage, please. Professor Shivshankar, sir, can you welcome Professor Periaswamy, sir, onto the stage, please? May I request Dr. Srivatsan to kindly be on the stage, please? May I request Dr. Arun Kumar to kindly welcome Dr. Srivatsan, sir, onto the stage, please? May I request Dr. Prakash Agarwal to be kindly be on the stage, please? Can I request Dr. Harry to kindly welcome Dr. Prakash Agarwal onto the stage, please? Ladies and gentlemen, the number of people inside this auditorium capacity is 96, is around 50. But we have to tell you, you are now being live streamed to 1,900 people all around the southern part of the country. 1,900 people are doing this program. So we are very happy that we are a part of this program. Thank you very much, sir, Professor.
Now my knees have started knocking.
Now it is over to other questions that to take to the panelists.
So the first question is to, it's a case discussion basically, all right? So we have a 3-year-old male with an incidentally detected right-sided abdominal mass. I know females get it more, but I just thought I'll turn it a bit. So the grandma was giving a bath, the child was okay and healthy and playing, and suddenly grandma notes, oh, there's something gas irukka enna theriyala. Okay, so she tells the parents who take him to the pediatrician. The pediatrician looks over the child, oh, nothing, and will anyway get an ultrasound. The ultrasound shows a right renal mass, possible right renal mass. So Prakash, what next? How do you proceed with it?
Well, if it's a 3-year-old male with a possible renal mass, definitely we'll go ahead with the contrast and CT scan.
Okay. And then you see this on the contrast enhanced CT scan.
Yeah, there's a huge tumor, I think, arising from the lower pole of the right kidney.
Okay. So what would you do now?
Looking at the size of the tumor, I think I can see more of the tumor rather than the kidney. So I would go for a neoadjuvant chemotherapy. What we do in our institute is we put it through the tumor board. Tumor board takes a call decision. But if it is my personal decision, I would always do it.
Upfront. Oh, neoadjuvant. Okay. Okay. All right.
Yeah.
So,
I'm adult urologist. So we have seen a very cool case of Wilms health institute. So this and the CT scan is our investigation.
right, sir.
And you told whether PET CT is needed or not.
Right.
Yeah, we do PET CT scan, and especially for metastatic workup. At the same time, post-operative, we also follow PET CT is very useful to find out any development of new metastasis. That's see, in adult tumors, clear cell carcinomas and highly vascular tumors, and we see a lot of enhancement during a CT scan with contrast. But here, Wilms tumor is also a vascular tumor, but there is not much of enhancement to see.
Okay.
Is it common to see it like this, or?
I mean, in this also, if you look at it, I mean, it's probably my projections, but they they do take up contrast, they do enhance, all right. And I would say I seldom see something that doesn't enhance in Wilms tumors.
Second thing is calcification.
Calcification, yes. Like I said, only about 5 to 10% of pediatric Wilms tumors have calcifications. And generally, they are peripheral calcifications, unlike in neuroblastoma, we have central calcifications. These are typically, neuroblastomas are called as stipple calcifications, whereas these are supposedly characterized as eggshell calcifications.
Yes. See, when compared with the clear cell carcinoma, other tumors, that's not a central calcification. It is called metastatic calcification. But the main differentiating point is peripheral calcification. If you see a peripheral calcification in adults, we have to suspect adult Wilms tumor.
That's why one of the cases I was talking about, when you're a nine-year-old girl with, in that gray zone, whether it's a renal cell carcinoma or is it a Wilms tumor, the moment you start seeing calcification, we tend to, as pediatric surgeons, think more in terms of a renal cell carcinoma, and we do, because the renal cell cancers do not respond to chemo. We don't want to give chemo unnecessarily, and most of us go by the SIOP protocol, so where it's a neoadjuvant therapy. So some of us go ahead and do a core biopsy of it, make sure that we are not missing a renal cell cancer.
Do you find a lot of necrosis in Wilms tumor? Or
Necrosis depends on the size of the tumor. I'll kind of show you one of them. All right. There's always a central necrosis when the tumor starts outgrowing itself. All right. And then after NACT, you'll see a lot of necrosis also. The size may be not very different, but there will be necrosis in the tumor.
The CT scan also shows the tumor is encroaching into the renal sinus area.
Correct. Correct. So 100% this child will get neoadjuvant chemotherapy. And that's it. So
one thing I would like to ask is the Doppler of the IVC.
very good, very good. Excellent. We'll get to that. Yeah, definitely. Those are things we do think of. So my point in this is, in pediatric Wilms, we don't necessarily need a PET CT, although I think both Ramchandra and we do PETs in all of them. Okay, as a follow-up also, it's a good thing. But the problem is they're expensive, cumbersome to get done. Children being hungry and fasting, they get really cranky. So
Is MRI is indicated in Wilms tumor?
MRI, more and more studies are coming that are saying that MRI may be the way to go. But as a surgeon, for me personally, I feel much more comfortable with the CT scan. What about you?
Even we understand the CT scan better than MRI.
Yeah.
Our reading of MRI is very poor.
Yeah, MRI we have to rely on the report.
Right? Yeah.
CT we ourselves we can read.
Yeah. So I guess that must be universal over here, right? Yeah. So would you offer?
What neoadjuvant?
Okay. All right. Neoadjuvant. All right. Neoadjuvant therapy in this particular child, okay, I don't see any nodal disease or anything. Yes, it's across the renal sinus. We go with two drug regime, okay, vincristine and actinomycin. Okay, we don't add adriamycin right at the outset. Okay, we go for 4 weeks with vincristine and actinomycin. Reimage. Okay, if there is significant resolution, then we go for surgery. If there is not enough resolution, or in this, it will respond quite well. But in other tumors, if you think you still need some more, the maximum you can go up to is 6 to 9 weeks. Past 9 weeks, there is no benefit in giving any more chemo. Okay, so that's what you do. Now, when do you use 3-drug regime? When you use a 3-drug regime, it's basically when you have other factors. If you have significant nodal disease, sometimes our oncologists tend to use. If you have metastatic disease, you tend to use. Now, metastatic disease, when I talk of metastatic disease in Wilms tumor, it's always, I'm talking of only pulmonary metastasis. I'm not talking of liver or bone, which are extremely, extremely rare. All of us would have seen one or two, but it's very rare. The incidence is so minuscule that it's not worth mentioning. And if it does happen, they're treated. If it's like I talked about a peripheral met in the liver, we resect it on table at the time. If it's a central met, you just leave it. And since they're all chemosensitive tumors, most of them vanish with completion of your therapy. So depending on the protocol, we go at least for 24 weeks, 24 to 27 weeks with either VA or vincristine, acnomycin, and doxorubicin. Prakash, would you offer NSS on this? NSS is nephron sparing surgery.
I don't have much experience, but coming to the present literature, a lot of people are doing nephron sparing surgery for unilateral tumors. Basically, to tell the PG that nephron sparing surgery basically indicated for bilateral types, where you want to preserve some renal tissue for the functioning, and you don't go into renal function. But for unilateral Wilms, yes, a lot of present papers are telling that you can do for a nephron sparing surgery if after chemotherapy the size is reduced considerably and you have a good plane between the renal parenchyma and the tumor tissue. What happens after the chemotherapy is they form a pseudocapsule where you can put a good plane between the normal renal parenchyma and the tumor tissue. That is where you can always plan for nephron sparing surgery.
Yeah.
So, yeah, nephron sparing surgery in adults, it depends upon the size of the tumor. So up to 4 centimeters now it has been extended to 7 centimeters. Up to 7 centimeters, peripherally located tumor.
I think that's a key. That word peripheral is key. You have a central one, right peripheral is correct.
And here you can see the tumor is extending into the renal sinus.
Yeah, this one obviously not. I just want to bring that in. Yeah.
The concept of nephron sparing is slightly different when coming to adult and pediatric. Though the anatomical placement of the tumor and everything matters, there is also a concern of whether the entire genetic change that is also going to be there in the rest of the cells that can develop. So do you see metachromal thing that can occur later or in the opposite?
I can show you one of them. Yeah, I can show you one of them.
Whilst we are at it, do you always go for an open approach, or is there a role of minimally invasive? I know it's a
we'll get to that. Okay. Number one, okay. Minimally invasive. All right. Two things I want to get to. Prakash was mentioning unilateral tumors with nephron sparing surgery. Yes, more of it is getting done. But is it, wow, the bell went, I got this long. Yeah. 15 more minutes. Yeah. So nephron sparing, okay. Although more and more people are getting into nephron sparing surgery, it's still in Wilms tumor is not standard of care as of today. It is still nephrectomy, right? Yes, we need to gain experience in protocols, in trials. These are there, and isolated surgeons here and there are doing it, but we should pull all that data and know where we are with all of that. And what is the impetus of why are we doing nephron sparing surgery? Because if you look at the long run, okay, 30 years down the line, a child with a unilateral Wilms that underwent nephrectomy, what percentage of them actually get into renal failure and chronic renal failure who would end up requiring a transplant or a dialysis dependent? It is still not very high. It's only 5 to 10% of them who would get into that situation. Right? But yes, it is there and technically feasible. And if it is safe, maybe we should go with nephron sparing when we can do it. Now, in terms of minimally invasive, there's a slide we'll get to it. Now, this is another kid, right? You see a viable tumor thrombus extending up to the almost diaphragm, above the hepatic veins. How would you approach this? Obviously, neoadjuvant therapy. I mean, we have done all metastatic workup. I'm just assuming that we have gone through all of that, but this is what we are presented with. So how do we go about this?
I think after 4 cycles of chemotherapy, you have to reassess again if the thrombus is persisting. It may be a thrombus without any viable cells.
Possible?
So you have to do an nephrectomy. Along with it, you have to remove that thrombus.
Yeah, that's true. Okay, we'll get to that. Now, when we have a viable tumor thrombus, all right, we automatically go from 2 drugs to 3 drugs. Okay, and typically, at least I tend to wait 6 weeks before I re-image them. 6 to 9 weeks is acceptable. After 9 weeks, absolutely no point in doing any further chemotherapy. No, yeah, just contrast and CT is enough. So, no. Okay, because at this point, whatever it is, whether it's a viable thrombus or not viable thrombus, it has to come out. Now, how does it come out? Are you going with are you just going through a midline incision and taking it out? Or are you going for a sternotomy? Okay, all that depends on the level of the thrombus. Yeah, so.
What is the role of preoperative embolization of the tumor? Is it adults we do only for highly vascular tumors? Pediatric age group, have you tried?
I have no experience with Prakash.
So I don't think in pediatric we do preoperative because the tumor tissue has to come out. We can't leave it there to embolizing it.
Embolization main idea is it will reduce the vascularity of the tumor. Preoperative, it's only a preoperative.
Yeah. Prakash or Center?
In that case, no thrombus in that scenario, or it's a normal.
In IDC thrombus, we generally don't prefer preoperative embolization because it can lead to when we are manipulating the renal vessel, there is a chance that can embolize. Generally, we avoid it when there is a case of.
Okay. Okay. Okay.
One more thing regarding thrombus. The decision to make regarding removal of the thrombus or do a venectomy is if you are seeing vessels with the thrombus where the blood flow is by the side of the thrombus, you then go for a thrombectomy.
Correct.
If you don't see blood vessels by the side of the vessel, you have to do a venectomy.
True. Now, venectomy, again, cavectomy in pediatric age group, if you're above the contralateral renal vein and you can take it up to the hepatic vein, there's no problem. You can do a total cavectomy. Okay. But if it is below the cava, which I don't have, I mean, below the contralateral renal vein, and there is a renal, very extremely rare, but if you have an incidence of a thrombus going towards the bifurcation, towards the iliacs, then what do you do? That becomes a question.
So most of these tumors, they will have a thrombus above the renal vein.
Correct. But
so the distal thrombus is very rare. The thing is, there is no need to excise the entire renal cavity. There are various techniques available. You can do a partial cavectomy.
Correct. You can do that.
And you can also put a graft.
Yeah, you can use a bovine pericardium. Saphenous vein in children won't work, sir. So
They put a saphenous vein graft. It's a fax graft they do it.
correct.
Total cavectomy is not done because we cannot totally occlude the renal.
Actually, in kids, I mean, all of us would have had circumstances where, the anatomy is so bad, you end up ligating the IVC, okay? But they have formed collaterals that I have a patient now, 5 years out, I've ligated the IVC and it's perfectly fine. The collaterals take over without a problem. My question is to the adult urologist about if you do, okay, have thrombus below the renal veins, okay, and it is stuck. You cannot even post NACT. You're not able to remove it. It's stuck to the intima. What do you do?
Actually, below the renal vein, it's a black thrombus. So tumor thrombus is there. Along the stream.
It's only a blood clot.
Okay.
When there's an obstruction.
Only thing, the problem of pulmonary embolism, the black thrombus.
No, but when it is in continuity with the tumor thrombus. Okay.
The thrombus growth was there. No.
I have not seen any tumor thrombus below the renal vein.
Okay. I
It's
was
all above the renal vein because of the blood flow.
in a meeting yesterday where I just saw one where they showed it. Okay, that's why that sparked my interest. But yeah.
But then for us, and as adults, we can target the IVC through the renal vein.
You can. The collaterals will take care of
We
it.
don't like it opposite. We
Okay.
are opposite in that way that we can like it.
You can like it. Below the renal vein, you can like it.
Okay.
But the renal vein, it has to drain. Above the renal vein, you have to like
So
it.
for us,
Problem.
Okay. All right. We're done with that. Oh, this is for Prakash. Your take on MIS and
I knew you would be asking me this question. Because I do a lot of laparoscopy for pediatrics. But having said that, we have done a lot of neuroplasty.
Yeah.
Not much of Wilms.
yeah. Can I get some help here? Yeah, I'm trying to get your presentation up. Can I get some technical help here? I'm a technical novice. I want this to come up now. Okay. Wow, that was cool. Do you want me to go to the previous slide, Prakash?
No, you can get down and can you put the other PPT?
I'll get down. This is yours. Yeah.
And go to the previous one. See if you see the surgical feasibility of doing a laparoscopic Wilms tumor surgery, you need to have that expertise. As in laparoscopy, you saw that there is a lot of time lag which people have to learn laparoscopy.
The learning curve.
Learning curve. So if you have a learning curve in Wilms tumor, it's very high, very steep. Similarly, you have to have an advanced knowledge about laparoscopy. You go in for Wilms. Next. So we 100% have to follow the oncological principles of having adequate margin of resection. If you are contemplating laparoscopy, if you have adequate margin, it should not be having minimal manipulation and the factor sensitivity is never there in laparoscopy. So you have to think about those things also when you're contemplating laparoscopy. Next. What are the technical pitfalls? There may always be a chance of fail or rupture when you are doing laparoscopy because
Sorry to interrupt, sir. Kindly use the mics.
yeah, sorry. You don't have the tactile sensation, so you don't hold the tissue properly. There is always a chance of spill or rupture when you are handling the tissue laparoscopically. So that problem is always there. And of seedling the ports. When you are removing through a port, ruptured tissue, you always have the chance of seedling. Next. And as you said, the lymph nodes should be harvested in all cases for lymph node sampling to stage the tumor. If you see the technical consideration, there is a SIO umbrella protocol, which have given clear-cut guidelines as to which tumor. So it should be a small tumor. There should be a periphery of normal tissue around it, and it should be unilateral tumor. Then only you should go for a laparoscopic resection. You should put it into a bag and take her to a financial incision. So these are my takes on a laparoscopic tumor surgery. Yeah, you can go there.
Okay. How do I escape from this and get back to mine? Oh, wow, that's pretty cool. All right. I don't see it yet. Anyway, how do I navigate to that now? Yeah, I got it. I got it. I got it. I don't know. Let me get to that. This one. What's your takes is on minimally invasive surgery? I know you guys do it way more than us. Okay, be it partial nephrectomies, partial anything.
Do a lot of adult very bad, but I'm not sure pediatric.
No. I'm talking of renal kidney oncology. Okay, how do you do it? How often do you do it?
Lap nephrectomy is a standard protocol for renal kidney.
Lap partial nephrectomy.
Yeah, partial nephrectomy is also that with a robot.
Okay.
I don't have experience. Lap nephrectomy is a standard.
Okay.
Since
Since
the robotic.
Yeah.
If you're any pediatric, robotic.
Yeah.
We get a lot of PHS.
Yeah,
Because
sure.
again, goes in the range of KSL cancer, but pediatric films and all I'm not done. Adult films and all we do minimally invasive. It all depends on the feasibility, the ontological principles, as you said. If especially the difference between adult and pediatric is that we don't have rupture of tumor and all in KSL. It's a very well pseudo encapsulated structure, whereas in Wilms, I'm not sure whether there is a higher chance of rupture. So the main thing is you have to be outside the xerotas, nowhere go near the tumor, do the lymphadenectomy and always blast the specimen before you take it out. That's the general principles that we follow.
We are still on the more cautious side of open.
Hi. Oh, Rajiv's class.
Yes.
Yeah, my partner's classmate. But I'm good.
We were undergraduate. We go more for open cautious.
Since we are almost done, here's something for, I thought I would play this, but it's not. We'll just play this. This is just a very interesting CT. Let's see who's got Hawkeyes in the PGs and what is the unusual thing that you see in this? Forget the tumor, forget everything else. What is it that, how do I play it? How do I, it's not moving here. Yeah, I guess I did that. And now, yeah. So, who's got Hawkeyes? It's not moving there. All right, we're almost out of time, but I'll desist with it. But if we can play it in the next 1 minute, $100 for the guy who can, $500 for the guy who can find out what is unusual about this. It's not playing there. Not very many. What about you? Yeah. Prakash, any CCS? Places are.
In the last 30 years, I've seen only one.
I have not seen. That's why I didn't put up things that I haven't seen. Okay, here. Forget the tumor. Forget the tumor. Oh, this is the wrong. Sorry, this is the wrong one. Yeah. No. Next to next. I think. Yeah. This one. Can we play this? Yeah. In this, forget the tumor, but there's something else that is very unusual. Forget the meds, forget the tumor, all that stuff. So the first person who answers it gets $500 from me. I'll play it once more and then I'll show you a static film. I know it is nitpicking, but it's a very unusual finding. Okay. Why is this not? Now do you see it? Can I show the mark on this? Retroaortic renal vein. He's not a PG, right? I said $500 to the PG who answered. So, a retroaortic renal vein. My thing with retroaortic renal veins is, as a chief resident doing an aortic aneurysm, I didn't realize it and I backed the renal vein. From that day, anytime there is a thing, I always look for a retroaortic renal vein, and it's only supposed to be 2 to 4% of cases.
It's common on the left side.
Yeah.
It
has to be on the left side.
On the left side. And we have seen a lot of cases. Donor refractory. But renal vein anomalies are very common on that side. And multiple renal veins are common on that side.
Correct.
About 28% of the cases. There are 3 type 1, type 2, type 3. Some aortic, aortic corner, urethral aortic, aziga system. So many things are there. Earlier, when we are doing conventional angiograph for donor evaluation, many cases are missed. But now CT angiogram, they do immunograph also. So we were able to pick up in the film itself, so that we go prepared during our donor.
Thank you. And I had a few more slides, but I never thought I'll get to 45 minutes event. But hopefully none of you slept like my dog. I now like our director of the session, Mr. Will state our speaker.
It's a great honor for me to do this. My classmate. Will say first time or LKG? Okay. Good morning. Okay. So. Oh. Thank you. We used to walk from. All right, thank you. Thanks. And there was a very excellent talk and excellent discussion, sir. I should thank all the panelists for making it very lively. And I think we should go for some more time, but want of time we are going to. Thank you very much, sir.
Thank you, sir. Right. To invite our next speaker, Dr. R. Madhu, sir, to deliver his talk on posterior.
Good morning, everyone. I'm Dr. Madhu, HOD of Pediatric Surgery from Ramchandra Medical College. It's really a proud moment to come back to your alma mater and deliver a talk. I walked into the MMC portals on August 1st, 1990, along with my two friends here, Velavendan and Senthil Ganesh. PR Saravan is missing in the crowd. He is also a part of our class. So, and I should thank Chengalurayan for giving me this talk in MMC. First time I'm talking in my alma mater. Thanks, Chengal, and the Institute of Urology and Professor Shoshan. So my talk is on posterior urethral valves. As a surgeon, we all feel that we are almost equivalent to God. We are able to cut and stitch. But certain diseases make you really humble and show you the ground or even below. And one is such as posterior urethral valves, and other probably is hypospadias. So these two surgeries, you'll think you have done a great job, and then you'll end up with disastrous complications. And posterior urethral valve is a disease which starts from neonatal period and goes till life. And we sometimes hand over the patient to the adult urologist for transplant also. So we'll go into that. So for the introduction, it was Young who described this term called posterior urethral valves. There are some chromosomal anomalies which are associated, chromosome 1 and 11p, and we have a rough incidence of about 2 in 10,000 live births, and it is only exclusively for male children. And we usually classify 1/3 become good, 1/3 have a lot of problems of bladder dysfunction and LUTS symptoms, and 1/3 go to end-stage renal failure and renal transplant. Stuck. Not able to move this slide. So it's the most common cause of bladder local obstruction. As you see, it's the obstruction is somewhere here. So we have bilateral hydroureteral nephrosis, and this causes a profound embryological insult right from inside the mother. The embryology of PUV, basically, it's failure of regression of the mesonephric ducts at the point of verruc formation. You have some normal posterior urethral flows which are called as plicae colliculae, and abnormal high insertion of these and the anterior fusion only gives rise to the valves, and it becomes like a rigid valve with a sail-like appearance. And this was Young's classification. Type 1, where the valve is just distal to the verruc, 95%, most common. Very rarely, I have not seen a type 2 valve so far. And this type 3 valve with the central hole is what Patty Dewan has given the name of COPEM, congenital obstructive posterior urethral membrane. So these are certain endoscopic images of the posterior urethral valve, and this classically, this one is looking like the COPEM. And this was described by Patty Dewan from Australia. So how do they present? We have to start from antenatal with good ultrasound and fetal medicine experts. Now we have come a long way in the management of PUV antenatally. The history of oligohydramnios will be there because the child is not able to pass urine. There is an obstruction there and a lot of lower urinary tract obstruction. In the neonatal period, they come with respiratory distress because there is not much of amniotic fluid which has to go into the lung and expand the lung, and some urinary stream complaints. And the worst part that you can have is the Potter's syndrome. We'll come to that later. And you may have urinomas, urinary ascites, and when they are born, the bladder is so thick, and with the T20 World Cup going on, it's called a cricket ball consistency of the bladder. When they come slightly later, it can have dribbling, poor urinary stream, urosepsis, etc. We'll go one by one. So for antenatal diagnosis, the ultrasonologists have come a long way with a high sensitivity of 95 and 80% specificity. Oligohydramnios is the feature. Apart from that, you have a thickened dilated bladder and bilateral hydroureteral. And you have this classical keyhole sign. And in the kidney, because of back pressure effects, you may have renal cysts or dysplasia. Fetal MRI is done in few advanced centers. Some of our cases in Ramkanta, the radiologists do that and they clearly document the hypoplasia. So this is the classical keyhole sign where that is the bladder and this is the urethra and that's the block there. But actually the keyhole sign is 50% or more seen in urethral atresia in girl children. For boys, about 40% exhibit this classical keyhole sign. This was the Potter's phases. Due to a severe block, bilateral renal agencies also happens. And that's the mnemonic where you have pulmonary hypoplasia, oligohydramnios, twisted skin, phases of Potter's, and extremities defect and renal agencies. This is almost incompatible. When they come postnatally, we have to do a ultrasound. That is the diagnosis where you can have there. This picture shows some urinoma there. The classical is a dilated bladder and bilateral hydrourethral as you see, and a dilated posterior urethra. To confirm the diagnosis, we have to do a MCUG or a VCUG, which is the definitive study. But this is done under antibiotic cover and theatre backing has to be ready. Usually, as soon as the MCU is done, we take up the child to the theatre for the valve fulguration if it's confirmed. The classical findings in a MCU is either you go from bottom up or from above, from below. You have a narrow anterior urethra, then a cusp-like thing at the posterior urethra, a dilated posterior urethra, hypertrophied bladder neck, thickened bladder. This wall of the bladder is slightly better. Sometimes it may be very trabecular and you may have a reflux associated also. These are really bad bladders. These are not my cases, luckily. And in the MCU, you can see the width of the posterior and anterior urethra, which will be a telltale evidence of posterior urethra bag. That is the transverse width of the posterior urethra to the anterior urethra. If it's more than 2.1, then it considers posterior urethral valve is highly possible. But there are some fallacies here. Some rotation may be there, age variable. So it can give fallacies too. Among the lab parameters, we don't do it first 48 hours because the urea creatinine will reflect the maternal values, complete blood count, and then we do the renal function tests and electrolytes, ABG. And the best indicator for long-term renal prognosis is the nadir creatinine. That is, you plot the creatinine up to 1 year of age, and the lowest value, if it's below 0.8, it's got excellent prognosis. More than 1.2, a paper has come from Sudipta Sen from Vellore also, so indicates very bad prognosis. So what is the pathophysiology of these valves? It is not just a block, like you are very familiar with your prostatic hypertrophy. You do a TARP, then they become really all right. But this is not the case here. Back pressure affects the entire renal tract. The bladder is initially compensated. It undergoes hypertrophy to overcome that obstruction. And with high voiding pressure, they are able to void. But this constantly goes on and then it goes on to a decompensated state where there is some changes in the bladder musculature. They are not able to void completely. They have increasing post-void residue. And that back pressure effect will affect the kidneys also and worsens the renal damage. And the end point is this, the valve bladder, where due to ultimate bladder dysfunction, due to a lot of bladder remodeling, this can even happen after a successful valve ablation because it's basically an intrinsic defect of the bladder itself. And the triad of that bladder is a polyuria, bladder insensitivity, and a lot of residual urea. This is what we call the Mitchell cycle also. So more and more pressure, more hypertrophy, tries to go across the pressure, and it is not able to, and finally the bladder dies. So the final endpoint is the myogenic failure with the valve bladder. The upper tract, the pressures are going up to the glomerular level and the ureters. So the glomerular will have affects the kidney, renal dysplasia. The tubules are unable to hold back the sodium. The loss of urine concentrating ability of the renal medulla and polyuria also. This is one point for the postgraduate students. We call it DURD or Duckett syndrome, which is actually a pop-off mechanism. where one renal unit absorbs the entire brunt, described by Duckett in 1982. The opposite unit is actually safe and compensatory hypertrophy occurs. That's what we call valves, unilateral reflux, and dysplasia. So that kidney is gone, but at least the other kidney is safe. If you have a pop-off mechanism in valves, the other ones being large bladder diverticula or a urinoma or a urinary ascites where urinary extravasation occurs, and a patent urachus. So child may be dribbling urine via the umbilicus. Then the brunt to the bladder is less. So the pop-off mechanisms are actually good. So once we make a diagnosis antenatally, then what do we do? And what intervention we have to do? So it depends on when you make the diagnosis. If it is done before 20 weeks and they have very severe oligohydramnios and it is done by two people, then this children will have very bad prognosis and have a CKD of more than 54%. So this we also would recommend medico-legal termination. In between 20 to 24 weeks depends on the prognostication. If it is having poor prognosis like severe oligohydramnios and already echogenic kidney or renal dysplasia is there, then guarded termination. But if they don't have poor prognosis, then we can wait till term with a monthly ultrasound. Between 24 to 34 weeks, this is the golden period if any fetal intervention has to be done. Beyond 34 weeks, we find out it's just monitoring till term. So if a fetal intervention happens between 24 to 34 weeks, what are we aiming at? We have to prevent renal damage, reverse the oligohydramnios, and get near normal lung and bladder development. So we have to do a fetal urine sampling, which is usually done by 20 weeks. 3 samples are taken at 0, 48, and 72 hours. And these are certain markers we see. Sodium less than 100, chloride less than 90, osmolality less than 200, and beta-2 microglobulin. Apart from that, even calcium and few other markers are there. But these are the main markers. So to improve the amniotic fluid volume, we do amnio infusion to maintain the amniotic fluid through amnio port. And that port is going into the amniotic space with a subcutaneous tunnel. And whenever necessary, we give saline infusion after an ultrasound if it's going in for oligohydramnios. If it comes, then what are the good criteria for any antenatal intervention? First, the diagnosis of PUV has to be confirmed. They have to be less than 34 weeks. Oligohydramnios can be there, but there should not be anhydramnios. A good dilated bladder and without much of renal dysplasia, normal karyotype. That's very important. And good favorable urine biochemistry. So what are the types of antenatal management? One is vesicoamniotic shunts. The other is fetal cystoscopy with valve ablation. And the timing is usually between 20 to 28 weeks. And there was a trial done by this Pluto trial. That is the only trial which has compared VAS with conservative management. And even in that, the vesicoamniotic shunt have only improved the neonatal survival, but not helped the end-stage renal disease or renal damage. So this is how the shunt was done. It was Michael Harrison in Philadelphia who started these shunts, where we put a shunt from the obstructed system into the amniotic space. And this drains off and improves the amniotic fluid also. But it has got problems because we have to give anesthesia. There will be some temporary fetal paralysis. So preterm delivery is possible. Abortions are possible. Mother is also at risk. And the main problem of these shunts are when they come for delivery, you can actually see the shunts outside. They're either blocked or they are displaced. Fetal cystoscopy with valve ablation was started with much fanfare. And we do it through an antegrade approach. But recently, Dr. Pramod Reddy came from Cincinnati and he was delivering a lecture in childress. He said they are almost stopped doing fetal cystoscopy with valve ablations. So when they come postnatally, because in India, I think in Chennai, only Dr. Suresh and his son, Dr. Srivatsan, are doing vesicoamniotic shunts for few selected cases. Most of it comes postnatally. So immediate catheterization, don't go for a very large feeding tube, but preferably a 6 French feeding tube only we use. And then you do all the blood investigations. After 72 hours of drainage, slowly the electrolytes and the urea creatinine will come to normal. And then you can take for primary ablation after 72 hours. But if they are in sepsis or high elevation serum creatinine, then a diversion is the better one. And we also have to manage the pulmonary hypoplasia, whether you have to ventilate them or give support for the lungs, we have to see. If they are having urinomas, we have to drain them. But the gold standard is a good valve ablation. And there are various ways of valve ablation. So we use either 7.5 to 9 French cystoscope, cold knife, Bugbee electrode, and diathermy hook are the common instruments used. But we have some blind instruments also, like a Fogarty catheter. I have seen Professor Prem Puri from Ireland do it in Childress. Under fluoroscopic guidance, he puts the Fogarty in, inflates the bulb beyond the valve, and just yanks it across. And then there is Abraham's valvotome from Amrita Hospital, Mohan Abraham sir. So it has got a very blunt knife. So he just passes it in, hitches it at the valve, and just tears the valve through. But the safest is, of course, seeing it and doing it. So I usually use the hook at a monopolar current cutting of 15. We use saline mostly. I have not had experience with glycine. And avoid aggressive fulguration in the neonatal period. This is something I want to tell the postgraduates, because you will end up damaging normal neonatal urothelium, which can cause strictures later on. Post-procedure, we keep the catheter for 72 hours. There will be definitely post-obstructive diuresis. And then our protocol, and most of the pediatric urologist protocol, is to do a check VCUG or ultrasound followed by a check scopy, because I don't aggressively fulgurate the valve at newborn period. So this is the hook. That's the cold knife. That's the Fogarty catheter. So this is a short video of how we do the fulguration. So once we actually have to go into the bladder, then come out slowly. Near the veru only you can see that's the veru. So beyond that, the valves will just fold and completely occlude the veru. So here I have taken video of both the diathermy hook and the cold knife. I am not a great proponent of cold knife, but my friend and partner in crime, Sendil, uses cold knife. So it should be fulgurated at 3 places, 7, 12, and for 12 o'clock position, you have to rotate the scope and then fulgurate it there. So we try to hook whatever is coming on the sides. So only the valve will get hooked very easily. And then you give short bursts of current and fulgurate the valve. So that is the fulguration going on. So you hook the valve there, and that's the valve fulgurated. So we can multiple short currents are done. And slowly you can see that the valve becomes less and less thick and papery. So this is for the 7 o'clock, I suppose. Yeah. So that was the fulguration done of the valve. If something is not getting hooked, better to stop. As I said, avoid aggressive fulguration in the neonatal period. And this is a cold knife. This video is from Professor Ramesh Babu, my colleague. I have never used a cold knife. One experience, I had a bad experience, so I stopped that. The same way, but you have to be more precise and cautious while fulgurating with a cold knife, because the knife is so sharp and it can damage the urethral. So in case we need to go for a diversion, if it's a very small preterm child, 1.1 kg, or you don't have the necessary equipment or the neonatal anesthesia facilities, then it is better to do a vesicostomy. The types are usually lapidus and bloxam, which is the commonly done. And this is a very innovation done by my friend Sendil Ganesh, who does button vesicostomy. He has taken the Mickey button of gastrostomy and put it for I thought it's an excellent innovation. He had presented it in our national conference and won a prize also. Because a child with a vesicostomy constantly keeps leaking. But when you put a vesicostomy button, the leakage is stopped. It is very easy to put a catheter and drain or clean also. But the commonest vesicostomy we do is a block-sum vesicostomy. And the vesicostomy should be done at the dome of the bladder, just beneath the urachus, where it enters the bladder. If you do it slightly lower, you will have prolapse of the bladder, and a good chunk of bladder has to be removed. And the bladder has to be stitched through the fascia slightly below, and the vesicostomy has to be above 1 centimeter. Otherwise, it will go for stenosis. The other diversions can be a distal ureterostomy, loop ureterostomy, sober, ring. If at all they are in very severe urosepsis, we have to go straight and do a loop ureterostomy at the earliest. And the one advantage of doing a ureterostomy in PUV children are the ureters are as dilated or even dilated than the colon. So you can't miss the ureter at all. The minute you open, the ureter only will pop out. So just take it out, do a loop, come out. That has saved few babies in my experience. So for prognostication, antenatally, we have the fetal urine sampling, I already told you. Postnatally, the nadir creatinine value is the most important. Below 0.8 is the best. There should not be any renal dysplasia. And the renal parenchymal area should be less than 12.4 square centimeter. If then they go for end-stage renal disease at 6 years. Other neoadjuvant surgeries which can be done. Always better to add a circumcision in most valves, especially with reflux. It reduces the chances of UTI. Nephrouretrectomy for dysplastic kidney of VURD. And role of ureteric reimplant, questionable. We'll come to that in the case scenario discussion. So apart from surgical treatment, medical treatment also has a very important role to play in PUV. So anticholinergics, we usually use oxybutynin at 0.2 milligram per kg to treat the reduced bladder compliance and overactivity. Tolterodine is more a specific muscarinic receptor, same dose, and the adverse effect of dryness and hyperpyrexia are slightly less. A new drug of sulfenacin also has come now. Alpha blockers, terazosin is very safe in children. The hypotension is not such a common side effect in children. And especially if there is a hypertrophied bladder neck, it's better to use an alpha blocker. And nighttime chemoprophylaxis to prevent urosepsis, especially in all cases of VUR. Almost 30 to 40% of PUV are associated with reflux. And involve the nephrologist early, because this is one disease you cannot manage as a surgeon alone, because they invariably develop some end-stage renal disease or renal rickets and other problems. You have to give vitamin D supplementation, calcium, soda bicarb, etc. So other adjuvant therapies include timed voiding. This is very important. The blood, they have to be told for double and triple voidings. Therefore, there is not much of post-void residual urine at all. And avoid constipation as much possible. So give some laxatives. Otherwise, they go in for bladder bowel dysfunction. CIC is very important, but unfortunately in boys, since the urethra is longer and very sensitive, many of them do not take CIC that well. So it is ideally initiated at an early age to reduce the sensitive complication. Then the upper tract damage is very less. If they are not doing a proper CIC, then we can even do a mitrofenol with the appendix, a viable alternative. Nocturnal bladder drainage. This Sudipta Sen only told us in one conference that he actually uses 7 different colors catheters. Every day one is used. So mother knows which day, which catheter she has a bag. 7 catheters are placed. This is very important because during night they have a lot of residual urine, which in turn increases the chance of UTI and worsens the upper tract. So best thing is to combine daytime CIC with overnight drainage to avoid all the complications. Now coming to some controversial areas. One is bladder neck incision, which probably adult urologists you do often. But I personally don't have any experience. Professor Yogesh Sarin from MAMC Delhi propagates this bladder neck incision, but it has not been adopted universally. And only for very severe hypertrophied bladder neck, we can do. Bladder augmentation. So when they go in for severe valve bladder and medical management fails, or the bladder is very spastic with thickened wall, we go for a bladder augmentation. The easiest available we'll think is the dilated tortuous ureter, but that also doesn't act well. So in PUV children, better to go for a enterocystoplasty. And renal transplant, more than 30 to 50% end up. And so that has mixed outcome. I think you adult urologists are much more capable of doing a renal transplant. In ICH, Professor Velmurugan has come. I think they have started renal transplant now, and they are also on the verge of liver transplant, I heard. So this is the follow-up of posterior urethral valve. This I have taken from the Journal of Indian Association of Pediatric Surgeons, 2019, a multi-centric study. Post-fulguration, 3 months, 9 months, 6 months, 9 months, 1 year, up to 15 years. Because there is an aphorism that the treatment of valve actually starts after the fulguration. And we have to go till they come to 15, 16 years. Professor Sridharan sir used to tell, till 15 years, the growth acts as the third kidney, and that takes up most of the protein. Only when they stop growing, the brunt falls on the kidney. So that's where we have to see where any changes occur. So all blood values and urine investigation are done then. The Chexcopy or VCG at 3 months, again a refulguration is done. A DMSA at 1, 3, 5, 10, 15 years. And if dribbling and reflux are present, we go for urodynamic studies. So that brings to the end of my talk. And some more scenarios are there, which we will discuss in the panel discussion. Thank you.
Thank you, sir. I would like now like to call upon our panelist, Professor Dr. R. Karnamurthy, sir. I would like Professor Perisami, sir, to welcome Karnamurthy, sir, with a Professor Arasi, madam. Dr. Senil Ganesh, sir. Dr. Kapila Swaminathan. Thank you, sir.
Kiran, we go to the case scenario. It's got stuck. This one, sir. So good morning, panelists. So I'll just put few case scenarios and from there we can go on. So this is a case 1, antenatal diagnosis of valves, presented postnatally with dribbling of urine. And we did a MCU and USG and took up for fulguration. So this was the MCU. For the sake of postgraduates, I request one of the panelists to just go through what are the seen in the.
This MCU picture. So this MCU picture, was just saying it's posterior to the valve. Findings include starting from above downwards. There is no obvious high-grade vesicoureteral reflux, but the bladder contour is irregular and spiculated. Looks like an elongated bladder. And there is a constriction at the level of high bladder neck, closely dilated posterior urethra. There are a few bladder diverticulae which are also seen on the lateral aspect. And just below the posterior, in contrast to the dilated posterior urethra, you can notice a thin anterior urethral stream. And at the distalmost end, you can also find that the child has got a phimosis. There is some collection of urine there at the propical level. So overall, this is confirmative of posterior urethral valve, the bad bladder, and no demonstrable reflux.
Excellent, sir. So this was the ultrasound, which again confirmed the irregular thickened bladder, and you can see one ureter which is very dilated, the left hydroureteral. And so we did an initial fulguration, and we did a check scopy and redo fulguration, as is the protocol in our unit. 3 months later, and a repeat ultrasound showed the, I think it's slightly blurred, but the hydroureteral nephrosis had resolved. And when they came for follow-up, this child had recurrent UTI and twice admitted for febrile UTI. So I probably shouldn't have put that DMSA. I'm sure with UTI, I think you would have gone for a DMSA. What would you like to see in the DMSA in this case? But even after a good fulguration, second time, this child still had.
The fulguration, I think it is not sufficient. Is the first thing. Second thing, there is a VUR.
Yeah, the initial there was no VUR, but ultrasound showed a right hydroureteral.
Because of the inadequate fulguration, the stasis, there's a compensated bladder actually, but it's postnatal. So the bladder pressure is going high. So every time inadequate fulguration as well as high bladder pressure varying, the upper tract goes for current UTI. That's the thing.
Fine. So we also thought the same. We did a DMSA to see if there are any scars on the kidneys, but the right kidney was normal, mildly less functioning left kidney, but no evidence of scarring. And 45, 55, which is clearly acceptable, and no obvious scarring. So what next? Karnamut sir was talking about high pressure. So anything medical management, Dr. Kabilan. Now he is 1 year.
Possibility of stitches, most viable population.
Luckily, it was not there because we did a check scopy at 3 months. That's why we always avoid very aggressive fulguration in the neonatal. Yeah. I think in the ultrasound, the urinary bladder is partially distended and not much of residual urine also. So.
Be very cautious when you're interpreting post-void residual. So if somebody is interpreting post-void, you have to watch for at least 4 or 5 voids, because the bladder is not trained yet to empty.
And one more point, think of constipation also in smaller children. So further plan we thought was as whether there was an inadequate fulguration or whether there's associated reflux. So for reflex, we want to do an MCU. For this, we wanted to re-scope. We thought we'll do both together. So we did a on-table check scopy and with the MCU. And this was the findings. You can see that the bladder is much smoother now than the one before. We can't see an obvious diverticulum. And when you do the on-table voiding phase, no reflex is seen. And relatively, that stream is better in the antiurethra, and the valve is reasonably fulgurated, and the hypertrophy is also. Second thing we always do.
So what about the role of urodynamics?
In a 1-year-old child, UDS is a bit tricky. I think UDS Senthil has a lot of experience. What will he do for 1 year? Whether he will do it or.
Yeah, suppose we have run out of options and we are still not able to figure out because there are no residual valves. The reflex is gone on the MC. So still, if the child is getting some UTIs, then I think we have to look at the bladder pressures. So for children around 1 year of age, suppose they've already initiated CAC, it's relatively easy. But suppose you have not initiated CAC, I find it still worthwhile to do the urodynamic study under general anesthetic. But when I say general anesthetic, over the years we've evolved the drugs in such a way that it just gets the child to sleep and it facilitates the insertion of the catheter. So after that, the child is just kept asleep for the catheter problems. And I feel like it does give you a lot of information about the bladder, particularly once where you're stuck with you.
You do general only midazolam and sedation or full general anesthesia? Totally relaxed or paralyzed?
They are maintained from zero. I think I don't know the exact percentage, but usually they set it at 3. You can go up to 9. Initially they set it at 3, but once the study started, it is brought down to 1. So the child is just left asleep. You can try with Prediclor, but what I wanted to become very distressing for the parents. Start with Prediclor, you get the outcome of the study. It becomes very distressing for everyone. Counsel them again to for the general anesthetic becomes hard.
Yes, Professor.
Both in this posterior valve and kids with neurogenic bladder, I find the pictures during the filling phase are actually more important than the voiding phase, but still, hanging there, we can still do the voiding phase. So what we do is we want both of the smallest size urodynamic catheter, and they can still void by the side. But in practicality, about only 3 out of 10 patients are able to do that. Most of them wake up because they are very light. They wake up at the time of void and then the catheter is out. And I use video for all these cases. You can still get a video of the reflex. But pressures, it's a little, leak point pressure is a little hard to figure out.
I think at this point of time, UDS will throw some strategy how to manage it.
We have done this in April. We have not done a UDS yet. We started Tropan at 2.5 milligram BD under uroprophylaxis, and so far, touchwood, 2 months, no UTIs. Next UTI comes. We were planning UDS, but we thought the child was very, very young and may not cooperate. Probably next time we will definitely. It's on follow.
Yes, actually, it's an ideal way to do it. It's an ideal way to do it, but honestly, I've not done it here. But when I got trained in Sydney, I got trained to do that. So you do the suprapubic catheter, wait for 24 hours, and then do the urodynamic study because the bladder is quite sensitive when you insert the catheter. But it's a better way of doing it. Honestly, that 2 things, I have not had the suprapubic pediatric catheters available, so that is the reason I have not trained.
One question from the house.
After surgery, persistence of bilateral process. Can it be an upper tract pathology separate?
But ultrasound was done. We have not done a DTPA or anything for the upper tract. But ultrasound, the hydronephrosis has come down, and on the MCU, there is no obvious reflex also. But we have not gone. Pardon, sir? No, it's come down. It's come down compared to the. Okay. Come down. Come down. Okay. Even letters. So this case is on Tropan and uroprophylaxis. Last 2 months, no UTI. Next UTI, we'll take the panel's word and do UDS. So going to the next scenario. This is also a post-fulguration In fact, this case was done by me and Sendil together at Child Trust. And this usually there is any reflex, we don't go for reimplant in a PUV. The teaching is they wait till 5 years. We are waiting, and then we did a MCU, which shows grade 3 reflex still persisting, and a DMSA was done for this child, which shows a 22% function. So what next? Options given to the panelists. We wait and watch. Persistent reflex even after 5 years of it. And only 2 UTIs. Last 1 year, no UTI, but the DMSA is 22%. Ultrasound, they have not given any clear renal dysplastic changes. So, will we sting them, or is there a role for reimplant? I mean, this is just even I don't know what to do.
So I would be supposed to react to normal. I was not getting any UTIs, but if it's a toilet trained child with no lower urinary tract symptoms, so you can understand. Suppose it's a higher grade reflex, you may not get UTIs, clear will be normal. But because of the refilling phase is toilet training, bladder negative. If none of this is happening, even if there is a high grade reflex in the child with urethral, the DMSA is showing reduced function, but persistent same function, I am not doing.
Agreed. Any other challenging opinions?
Can I say?
Yes, sir.
Looking at that MCU, one of the things I'm concerned about is the bladder neck appearance, which is a sequelae of this valve syndrome. So there may be a role in giving alpha blockers. That following up. The absence of UTI, this dysplasia kidney, that may be the function that started off with.
Yeah.
And in addition, sometimes because this system with the poorer functioning kidney acts as a buffer, it may be protective to the other kidney.
Yeah.
So as long as there is no pyelonephritis, better to leave it alone. It's some alpha blockers.
Yeah, we have started alpha blockers, and I am not planning to do anything now. And coming to the last case, this child was fulgurated in the newborn period elsewhere. Presented at 6 years of age initially to Savita Medical College, where Dr. Jai Duraraj saw it, with mainly dribbling of urine. And no UTI. He was on tablet Propan 5 milligram, but he was not tolerating that due to the severe rash and hot feeling. It was reduced to 2.5. Dr. Jai had done a UDS there. So I would like the panelists to comment on the UDS. We have repeated one just last week. He was very cooperative. Okay, we'll go to the next UDS one. This was the MCU we have done now. Please, on the MCU, some comments. Dr. Karnamurthy sir. It's not a very great film, but it was a lot of fecal loading. This is basically
You're putting a small capacity, high pressure.
Absolutely.
So instead of putting that anticholinergics,
Yeah, he is on antidote.
no. Starting after that also is dribbling.
Yeah.
So UDS showing a high pressure.
Yeah, this is the UDS done, Euroflow and UDS done. Recently. Last week it was done.
So you have to go for augmentation or some additional procedures.
That is the questions which I wanted. So options for management. Because it is definitely his bladder expected capacity is 270. At 150 itself, we added the bladder sensation and couldn't control beyond 170. So what are the options? Okay. Yeah, that's what. I have not tried Mira background. I have no experience.
And we try Mira and see whether the bladder capacity is putting the pressure in the bladder is falling down.
Okay. Botox and
improve the bladder capacity. Before augmentation, probably we can try some more considered for
Mike.
Any pressure, even in slow bleeding, it is totally gone down
Yeah.
by bleeding.
Yes.
And this child is totally incontinent.
Yes.
and 8 years old. Yeah. Competition.
So did you, sorry, I mean, I saw the initial UDS, it showed a non-compliant, the initial UDS showed a non-compliant, it's not hyperactive, it's a non-compliant bladder where we have to be a little more, you take the myogenic failure out of the equation. So this particular UDS, a non-compliant bladder, you have to be very aggressive in your bladder management. So yes, I will start off with drugs. If propan is not working, I will start. This is a 7-year-old child, so you have the option. So mirabegron, I have not found it very useful in posterior urethral valve, but in neurogenic bladders it works very well, and in dysfunctional bladders. Posterior urethral valve,
Sulfanescent.
I will gently start to roll it and step up to sulfanescent, but I won't waste much time. In a couple of months, if nothing is recovering or things are worsening, I go in for a botulinum toxin. But the key is that you should establish good bladder drainage before you get them on the bottom. You should establish good bladder drainage either by CAC. And
that's one point. He was not good at CAC at all. He was not doing CAC. He was not tolerating at all.
Button very big. See, the vesicoureteral button is very much agreeable to parents because it doesn't involve opening the abdomen or opening an upper stomach, getting a piece of intestine. And eventually, as we are all aware, microphilum has got its own share of complications, particularly in the wrong limb. This vesicoureteral button, excepting for the fact, the sensation of the surgeon of having a foreign body inside the bladder, does not have any major complications, particularly when constructed in the right manner. And it provides a good drainage. It's very easy for the easy acceptable to the parents and to the child. So establish good drainage, go for Botox, but still on top of that, if it's not working, as we are all aware of the major complications associated with bladder augmentation in the wrong run. Yes, we were doing plenty of augments, but Professor Renal sir also might agree, like augments, we have found out they create a lot of problems. But we hand over to you, fortunately.
This child in old age, definitely go for SRP.
Yes, that is the last point.
But about future also, now we can augment bladder, where we can prepare the lower tract for that future renal transplant. It's better to go for
As an adult urologist, would you prefer a bladder being augmented before transplant? Will it hinder your transplant? Where do you put the urethra? Into the transplanted bladder or naked? Just out of curiosity, I have no experience. Usually we do an entrosystem. Ilium.
So actually, in our institute, Professor Jaraman sir, and we also did 1 or 2 cases. We will, that case, we will do in this totally gone. This one.
Okay.
If patient is willing for CAC and everything, can go for this thing, continent
CAC.
Otherwise, we will usually do a real convoluted thing. Prepare that without putting any ureter in that. For future transplanted ureter, we will put it in the real convoluted.
Dr. Madhu.
Yes, sir.
This patient has got hardly capacity.
Yes.
But the pressure is very high.
Yes.
So our aim is to reduce the pressure. So what I have done in few cases, I do clamp cystoplasty, where I make an incision in the dome of the bladder and put a patch of ilium. So that will reduce the capacity of, pressure inside the bladder. To an extent, it will improve the capacity also. This has to be done prior to transplant, about 6 to 8 weeks, or even 3 months prior to transplant. After that, we do transplant, and we ask the patient to go for CIC. They have to do CIC. But one of my patients, he is voiding normal. He had a posterior valve encourage group. He developed gallbladder syndrome, and I did a clamp cystoplasty and did a transplant.
Would you not add a mitrofenol while you're doing a clamp system? You would allow CAC.
Because his urethra is normal. His urethra is normal. He was able to, his mother was able to catheterize, and they were able to empty.
Thank you. Dr. Wilms.
I don't know, Zenthil mentioned here, so if the concern is just high bladder pressure and whether CIC alone is enough. We at ICH and elsewhere, and we also know we at Zenthil and also, we do a simple Mickey vasectomy. We use a Mickey button, which was originally designed to do for gastrostomy. And that is available even on tender. I made it available on tender across all government hospitals in the state. Now, you put in a Vicky button of size 12 or 15, 12 should be enough. Put it as a vesicoureteral, small, minor outpatient procedure. And then it can be, the idea is it will be dry, don't leak in between. There's a patient and the child, depending on the pressures, can open it every hour, every 2 hours, every 3 hours, and put a nighttime tube also if necessary. It just avoiding any disruption or disfigurement of the bladder, keeping it safe for future adult procedures. So I think that option should be looked at by us. We have found it very successful managing bladder pressures.
Excuse me, Professor Bhatt. For the bladder capacity, how it addressed? So you will
See,
do
this is
augmentation?
no. I am addressing only the bladder pressures, not the capacity. That is different. Okay, if it's a small bladder, obviously you have to.
Sir, one small sir. Yeah. So initially we start with the small bladders. It's not like an adult.
Yes.
Because the child is going to grow and the bladder might get bigger in size ratio. Suppose we augment the bladder at childhood and at later part of life, the baby will be having a bigger size, very large size bladder, and that itself can cause a problem. So whether it is wise to go for aggressive augmentation or like what Wilms sir has said, go for a button vesicoureteral and manage.
By the way, even for
The time being.
I have stopped using a microphone.
Yes, sir.
I don't remember the last time that work has been taken over by my
Button.
And that stem,
Yes.
you can ask him to keep it longer, shorter.
Yes.
So that actually works well.
Even though on the MCU, the bladder looks so big, it's more of trabeculation and hypertrophy. So the actual capacity of the bladder will be very small. So early cases, we have to go for augmentation as Karnam said. Of course, we have to try medical management of sulfasalazine or Rolitin. That fails, then a vesicoureteral button. If that fails, augmentation, and almost 1/3 of cases will finally end up. Yes, Professor.
Actually, yesterday we had a small discussion regarding transplant and a patient with posterior urethral valve. So some of the pertinent questions raised were when the bladder is not adequate and the patient is got a grade 5 or 4 reflux, high grade reflux. What is the role of, how do we proceed? Do we augment the bladder, keep the patient on CIC? This is for a patient who's grown up, it's not a child. So there are 3 questions which were raised. One is the CIC. 2 is augmentation of the bladder. Second point. 3rd is, in a case of high grade reflux, do we have to do an nephrectomy on that side? And 4 is, what is the problem of long-term CIC patients? So
the role of long-term antibiotics in the post-transplantation.
That I have no experience, sir. But in an adult, the high-grade reflux is almost a burnt-out disease.
I have already discussed about the Bowel-bladder syndrome, where when the before transplant only we do augmentation, not in the encouraged group. So about 6 weeks or 3 months before transplant, we augment, and I did a clamp cystoplasty, and after that I did. And when there is a reflux, suppose if the patient has got a repeated urinary tract infection, because the nephrologist, they won't accept an infected system in a transplant patient. So you have to do a nephroureterectomy when there is a high grade reflux with repeated urinary tract infection.
So that was acting like the VURD syndrome. It's a burnt out disease, better to go for nephroureterectomy and augmentation and then go for a transplant. Really 1/3 of PUE patients will probably end up with transplant. With that, we come to the end of the panel discussion. I thank all the panelists and I thank the Institute of Urology and Professor Shivashankar for giving me this wonderful opportunity. And I really wish Professor Prakash a very healthy and happy retirement. Thank you, sir. Thank you, everyone.
Thank you, sir. I kindly request Dr. Wilms sir to felicitate speaker. Dr. Wilms sir and Dr. Madhu are classmates.
Daughter and my son are
First of all, I congratulate Dr. Madhu for his excellent presentation. The PUV is a very complex topic. He presented in a very simplified manner. So it will be very much helpful for our postgraduates. Definitely, I congratulate. Excellent presentation. Regarding that last case scenario, regarding that for high pressure, especially pre-transplant patients with high pressure bladder. So what are the options available? Like there are three options likely. One is just medical management with the CIC with anticholinergics and alpha blockers. Second option will be augmentation with clean catheter stoma like midrophenops. Or third option is augmentation with the CIC. So in young patients, managing CIC augmentation with CIC is little bit troublesome. It will be better managed with the midrophenops, I think. What's your opinion regarding that?
CAC in boys, it's very sensitive. They don't do it much. So that's why the other option with single and male.
Yeah, managing midrophenops is always better in young population for long.
Instead of midrophenops, you can also try the vesicoureteral.
So anyway, I'm happy to felicitate my classmate Dr. Madhu. I call upon Dr. Sindhu Ganesh also to the stage. I call Professor Dr. Varamadi. She's also a classmate. He's a professor in Stanley Medical College. Especially for this presentation by Dr. Madhu from Stanley.
Thank you, sir. We always know that mother is going to rock. Thank you. Mother always stands tall at 6:03 to right to the beginning of this program. It's time for our inauguration to start. So we request people who are inside to stay back and people who are outside, we just a small request for people to come in. Our inauguration program is going to start shortly.
பாஸ் போட்டுடலாமா? இப்போதைக்கு பாஸ் போட்டுருவோம். பாஸ் போட்டாலும் அங்கே பாஸ் தான் வரும்ல. யூடியூப் லைவ்ல பாஸ் தான் பாருங்க. ஒரு ப்ரோக்ராம் பாஸ்ட்னு அது 2 மினிட்ஸ் ஆகும்ல. இது இப்போ பாஸ் எடுத்துடுவோம். இந்த மீட்டிங் ஷோ மீட்டிங்கோட இது
Thank you all for the inaugural session of this pediatric CME program. May I request the dignitaries to kindly occupy the dais, please. But the best way of learning is to teach, and who other than Professor Shiv Shankar can be said as an example for this. Not to take any credit away from his predecessors who have done a lot of good job here, but ever since Professor Shiv Shankar sir has come, the academics has been on their flow here in Madras Medical College.
Please don't tell this in front of Professor Arjay, sir.
I don't take any credit away from the predecessors.
Professor MGR sir is there, please. They're all my super teachers icons. Yeah. So good morning to everyone, sir. I welcome our Dean, sir, who has been always encouraging for us and appreciative of our work. And I always tell young and dynamic and energetic Dean we have got here, and who has been a guiding force for all of us. And I welcome you, sir, for this scene, sir. And in spite of British, yes. Now you understand, sir, who's better. And I welcome our VP madam for this session. And this is a session on pediatric urology, and our team sir is a pediatrician by himself. So this topic may be their team also. And so we have people from Apollo and from our own ICH and from CMC Dr. Chandra Singh is concerned. And we have from Mehta Hospital. So we have a group of pediatric surgeons here, sir, who have been doing very good job here, sir, and very useful for the PGs and also for us. Thank you, sir. Welcome you, sir, for this CME, sir.
I very request Professor to kindly proceed or deal with the shawl and dance.
I'll answer.
First, Professor J. sir to kindly proceed the Vice Principal Kavita ma'am with a shawl. The mail, please join. May I request the dignitaries on dais to put in light so that we can start it in our position.
Thanks, sir. Good morning, sir. Please come. Sir, good morning. Yes. Okay. Sir, please go.
This gentleman, the CME is now officially inaugurated. Now, great men make things look simple because they have mastered the fundamentals. And one person who has mastered the fundamentals of administration here is our beloved team. To come first to the hospital and then go last to the hospital, and more important than that, this diverse department in this hospital, bring them together in one unit as the albatross of Madras Medical College, We are blessed to have you, beloved team, sir. We have requested to kindly have the inaugural letters for us, please. Very good morning. I would say I would like to thank Surgeon so that is this first today's topic is the pediatric being a pediatrician. I know pediatric urology is one of the important. Many times the children are brought to outpatient department for simple urinary tract infection. Without the proper investigation, many times they land up in the scarring and the CKD and the chronic renal issues and so on. Unless you do a proper investigation, if you identify the issue early, and if you put them on prophylactic test, then only we can protect the kidney. Otherwise, many times, many children are being affected, especially teenage children, affected with urinary tract infection. Simple hygienic measures and simple investigations definitely will identify these issues in early stages. Once we identify early, then the prognosis and outcome is excellent. And our postgraduate definitely will be sensitive about this. And having this program, CME on pediatric urology will definitely actually help the postgraduates in knowing the pathophysiology and other aspects of pediatric urology. At this juncture, I just wanted to share with you all that we have put an MOU with IIT Madras. Instead of the first of its kind, we have started this memorandum of understanding with IIT Madras. We wanted to collaborate with them, mainly technological aspects. Once we identify the technological aspect, definitely when you bring it to patient care, the outcome as well as the diagnostic thing, on long-term prognosis, so many things I think we can improve it. So that's why we started this collaboration. I think urology department should come forward, and if you have any areas to be incorporating with the IIT, then definitely we can incorporate with the IIT people. We are planning to send our postgraduates, especially MS-MD postgraduates, and annually we are taking almost 483 postgraduates. So totally we have 1,283 postgraduates in the hospital college, the highest number of postgraduates studying in MD. So if you give a very fruitful and meaningful patient care oriented topics in dissertation, definitely this will help in long term for the patient management as well as for the treatment and other aspects. So that is the initial plan we have. We have actually planned for a short term as well as a long term plan with the collaboration with the IIT Plus. And I think the senior faculties have come today. You can have a discussion. You can come forward with any proposals to collaborate with IIT Plus. And also, Madras Medical College, the first institute to start a young PhD program in collaboration with ICMR. And three candidates will be shortlisted. We have sent 6 young faculties to Delhi. Shortly, they are going to have an interview. Out of the 6, 3 will be selected, and each one will be getting 50 lakhs grant for the whole program for 5 years period. And once they complete PhD, they will be posted as assistant professor. They need not undergo this senior resident and other things. So much of growth is there. I think the young faculties in urology also can think over it, and then they can submit it to the next year also. We'll think over it. At this juncture, I just wanted to say only hello to Prakash sir. We wanted to have an official superannuation function on the 28th of this month. Dr. Prakash and Sir Shankar are seniors in Stanley Medical College, 1 year immediate seniors, very friendly during the UG period itself. And even now, the way of approach towards the colleagues as well as the interpersonal relation, all those things are very excellent in urology department. That actually I wanted to thank you all. And I wish this program a grand success. And thank you, Onata. Thank you very much, sir. May I now request Mr. J.V.S. Prakash to kindly come forward to the vote of thanks, please.
Dignitaries on the dais, most respected team, most respected
Vice Principal Madam, our beloved Head of the Department, Professor Shivshankar, dignitaries of the dais, my senior professors and teachers, my good friends, and my students. I thank you all for coming to this CME on pediatric urology, which is of sometimes we are not very familiar with the problems of pediatric urology because we are more used to seeing the adult urology patients. Hence, we are very grateful to the Dean and the Vice Principal Madam for having come and graced our occasion. Thank you so much, sir.
I just want to introduce our speakers to our Dean, sir. Dr. Prakash Agarwal, please. Dr. Sandil, please. Dr. Madhu is there? Dr. Madhu? He's from Ramchandra.
Chandra Singh and Dr. Velmurugan sir can kindly join the list, please.
Respected professors, friends, and colleagues, this is on behalf of KMC as our HOD, Professor Parayasam sir, retiring next month. We are planning for our CME to felicitate him. And please all of you come and raise the occasion. Our invitation will be posted, we'll give it in person. Here we have invited Dr. Nambirajan sir. He's from UK, Information Faculty. It's mainly for postgraduates. We have even planned a post-lunch session where we can discuss oncology. He's a robotic oncology surgeon. He's a renowned person. Please come and make use of this occasion. We'll individually post and we'll come and hand over the invitation. Please, all seniors, PGs, please come in large number and raise the occasion. Thank you.
Sir, disturbing the booth. No. Disturb the same.
Thank you very much for just staying on with us. We are perfectly on time. Dr. Chandra Singh is going to be the next speaker. And Chandra Singh actually requires no introduction for his quality. Right from the younger age, when I had seen him as a colleague, the way he started his post-graduation, the way he used to speak, we knew that we are going to have someone who is going to be on top of this thing sometime or other in this time. Now, he's still young. He is only in his early 50s, but he's already established himself as a wonderful speaker and a wonderful clinician. And for us, he has come all the way from CMC Vellore. And we know personally he had a lot of difficulties. In spite of all those difficulties, his made his position came in the morning for us. Thank you very much, Chandra, for coming for us. We have a big hand for Chandra Singh, please.
Yes, sir, please. இப்பதான் ஆன் பண்ணீங்களா? கனெக்ஷன் போட்டு அங்க ஆன் நெக்ஸ்ட் இந்த மோட்ல வந்து ஒரு நிமிஷம் மோடு மட்டும் மோடு இந்த மோட்ல இருக்கு மோட்ல இருக்கு வேணுமா? வேண்டாம் வேண்டாம் நோட்ஸ் வேணும் இல்லை எப்படி இருக்கு? ஓகே ஓகே இப்படி இருந்தா பெட்டர். ஓகே தென் ஓகே சார். ஓகே ஓகே சார் தட்ஸ் ஓகே.
Good afternoon, everyone. I'm extremely grateful for this opportunity to be here. Special thanks to Professor Shiv Shankar and Professor Prakash for this opportunity, and Dr. Sanil and the MRC team. It's indeed a great privilege to be a part of this teaching program, especially as it is focused on the children. And the topic that has been given to me is a topic. Sure, I won't actually. Topic that is very important for us as urologists and trainees to focus on. One is because when we are practicing as urologists, we do come across children who need to be taken care of very well. The second is a good number of these children who have been cared for by pediatric surgeons are handed over to us at a later stage. We need to be able to take care of them. And the most important of it all is that there has been a radical paradigm shift in the last 50 years in the management of vesicoureteral reflux. I still remember as a postgraduate trainee, when I was attending the rounds, one of the senior consultants saw one patient who was there with a vesicoureteral reflux. It's a 20-year-old girl, and she was seen in the outpatient clinic 2 months before that. And he asked, was she put on prophylaxis? And then the team said, no, she was not on prophylaxis. Nothing had happened to her. And then he said, you will be failed in the exam if you do that. And that is the understanding which was there at that time. But things have changed radically. So in the next few minutes, I would like to focus on some of the important aspects of where all things have changed. What all have changed in the management. Just to focus on that and not to go into basic aspects which most of us, I'm sure, will be either familiar with or will be able to gather from the textbooks. So my focus will be on these aspects. Where do we stand in terms of the renal dysfunction associated with vesicoureteral reflux? What do we think and what do we know about the antibiotic prophylaxis? What is the role of bowel-bladder dysfunction in vesicoureteral reflux? And have there been any changes in the surgical interventions? And about this stratification in terms of children with VUR. Do everybody fall into the same boat, or we have any difference in their risk profile in terms of further worsening and deterioration of the renal function? So first we focus on the renal dysfunction. And what is what are the factors which predict further febrile UTI and scar? Because the moment we know a child has a vesicoureteral reflux, our first question is there a likelihood of further worsening of the renal function? So we know that if it is a child who's got less than 1 year of age, and if it's a higher grade reflux, and white race more than Caucasians more than our Asian race, and if there is a presence of a renal defect to start with itself, or if there is a bowel-bladder dysfunction, these are the parameters that should make us to be on alert, because the probability of further worsening or further renal deterioration is high in these children. So when any of these are there, when we evaluate this child, we should have in the back of our mind that this particular child needs further management, little more aggressive follow-up and care. Then what about the scars and UTI? It is quite evident that the more the number of urinary tract infection episodes that the child develops, where it is a pyelonephritis, that pyelonephritis results in parenchymal damage, which results in renal scars, which results in reduced renal reserve, which may either progress on renal failure or increase risk of hypertension. So our goal is to reduce the number of episodes of urinary tract infection. So what we know about the scars and urinary tract infections? We know that the probability of a child who's having a fever due to urinary tract infection, if there is a high-grade UR, is close to 90%. What that means is that there is nothing like a mild cystitis in a child with a high-grade vesicoureteral reflux. And 50% of these children who develop pyelonephritis. And also these scars, about 1/3 of them go on to develop hypertension. So that is why the children with a higher grade of reflux, bilateral, younger age group, we need to be far more aggressive than an instantly detected low-grade reflux in an older girl who did not have any problems till then. And that is how we stratify the risk in our mind. Because on one hand, somebody with a lower risk, we don't want to hit them with a hammer telling you need aggressive management, you'll develop kidney failure, you'll develop this problem and that. And on the other hand, a baby with a high-grade reflux and dysplasia, if the parents have not understood the magnitude of the problem, it is our role to ensure that they understand and they comply with follow-up. So you know that about 36 to 56% of children with VUR and UTI develop reflux nephropathy. And those who don't have scars also, 15% develop following first episode of UTI. And in the boys who have bilateral hydrocephalus and reflux, they have congenital nephropathy. And that's a parameter that we need to keep in our mind, because some of this nephropathy that exists to start with manifests later. So this boy might not have any infection at all, but photopenic area shows up in a DMSA scan later. And it is important for us to understand that it's just that it was not seen in a scan before, but it did not occur as a result of lack of treatment or negligence from our side. And there are two broad groups of nephropathy. What happens before the baby is born versus what happens as a sequelae to repeated episodes of UTI. If anybody wishes to have the slides, just send me an email. I can send it to you. I have no problem in sending it to you. So in terms of the congenital, that occurs when the renal nephrogenesis occurs, unlike the acquired one which happens after the urinary tract infection. And in the congenital nephropathy, the episodes of infection are uncommon, but in those which are acquired, the episodes of UTI are common. Now, why is this point important? I would like you to pay attention. We do encounter individuals who present at 15, 16, 20 years of age with high-grade bilateral severe reflux with absolutely no infections. So there, it is not that the infection has caused further renal damage, but they are born with congenital nephropathy and dysplasia, which has manifested when the renal requirement has become more, when they go through adolescence and with a higher BMI. And then also about the grade of VUR, the acquired, it may be a smaller or lower grade, but congenital, it speaks of a high-grade VUR concomitantly with nephropathy. And also in renal histopathology, the dysplastic changes are seen in congenital nephropathy, but it may not be seen in acquired ones. The long-term follow-up. This important study, which was published about a couple of decades earlier, is about this 302 children who had high-grade vesicoureteral reflux. And one group, there's not a randomized controlled trial, but one group was followed with medical management, conservative, antimicrobial prophylaxis. If there is any further issues, then you go ahead and do a reimplant. Next group was treated surgically. As soon as they had the reflux, they were reimplanted. Now, if you look at the numbers carefully, with a 5-year follow-up, even in those who are operated, 21 of them developed new scars. This is important information. They never had any pyelonephritis after that, but still they manifested new scars. But on the other hand, those who are managed medically did not have disproportionately more scars, as long as there were no episodes of UTI. That is important because in a child who is diagnosed to have vesicoureteral reflux, where there are no repeated episodes of infection, an operative intervention may not be required. That is the point I would like to drive into. Now, this is the same group that is followed up after 10 years. The 223 children, medically managed 113. Those who were operated in spite of that, one developed a new scar. In the medically managed ones, only one developed. So it goes on to prove that operative intervention as a role, as a purpose of avoiding scars is useless, which is not what we believed 30 years ago. 30 years ago, we believed that at 5 years of age, the reflux has not settled, you have to operate, you have to reimplant. Only then you prevent the chances of further scar formation. But science does not support that. So then we go on to focus on the next aspect, that is about the antimicrobial prophylaxis. So we have come a long way with a lot of things that have happened. You can broadly categorize that into 3 eras. One is a pre-2000 era, where continuous antimicrobial prophylaxis was noted to reduce the incidence of scarring because of reduction in pyelonephritis episodes. So that was being intensely propagated in the pre-2000 era. Then the second era is 2000-2008, where there were quite a few randomized studies, especially from the European continent, and they were in various European countries. So where they said, though CAP seemed rational, it came under scrutiny because they were concerned about the antibiotic resistant cost implications and the carcinogenic potential. Now we all know that the number of bugs that we have, which are multi-drug resistant, is so very common in our country. On the other hand, 2 weeks ago, I got a sensitivity report of somebody from California who developed a urinary tract infection. So his antibiogram, of the 15 drugs, it was sensitive to all 15 medicines. Nitrofurantoin, cotrimoxazole, ciprofloxacin, amikacin, gentamicin. So that is the magnitude of the impact of indiscriminate antibiotic use in our subcontinent. So much so that the Western world looks at us as a storehouse of these terror bugs. And when you see that prophylaxis can also lead to increased propensity to multi-drug resistance, that is why in the second era that came under scrutiny. So they felt that agreed it is reducing the incidence of pyelonephritis, but probably may not be indicated in all children, because there is a subgroup which needs an aggressive intervention and operative intervention. There is another subgroup which probably does not need anything to be done. There is a subgroup in between which requires a chemoprophylaxis. So can we subselect that group so that the benefit may be offered to that group which definitely requires it, but avoiding the other two groups, thereby reducing the side effects related to that. That was the second era. Then subsequently, we had the reflux of these European studies like Kessler, Penesi, Montenegro. They all showed that probably not. So that is why we went to the next one. The third phase is where we had this PREVENT trial, then Swedish reflux trial, and each of these, including the RIVER trial, came up with specific indications as to where this antibacterial prophylaxis is required. And they studied in 607 children with grades 1 to 4, predominantly being grades 2 and 3, median age of presentation of 1 year. 91% of them were started after the first episode of UTI. And it was noted that in the uncircumcised males and in bowel-bladder dysfunction and concomitant high-grade reflux, there is a distinct benefit. The other groups, we have discrete based on underlying scars, the likelihood of this child being available for follow-up, compliance of parents, incorporate these parameters, and then make an individualized clinical decision for that particular child. So then we go on to this bowel-bladder dysfunction. This has been in focus in the recent years, much earlier in other countries, in developed countries, more so in our countries. What has happened in the recent times? Junk food has increased, carbohydrate drinks have increased, regular diets have changed, vegetable intake has changed, parental supervision of children has changed. Most of the schools are now offering food diet, which is not being supervised by the parents, because of several of these parameters. And on the other hand, children's entertainment patterns have changed. Earlier, children were going out and playing. Now there's no place to play. Earlier, there were no gadgets. Now there are so many gadgets. So children tend to postpone both maturation as well as their bowel movements. They suppress that
till they reach a point when they can't hold any further. And all this resulted in a very close association with urinary tract infections as well as with vesicoureteral reflux. So it is important for us to keep that in mind and look at that aspect also, because often we don't ask specifically how the bowel habits are from the parents. Even if we ask, parents out of embarrassment give an answer that may favor the doctor because they don't know actually what is happening. And unlike the Indian earlier habits where parents would see where the children are past stools, now they can't get to see because the stools have all been flushed. So if you ask, was it hard stools, was it soft? The last time they would have seen was when they changed the diapers when the child is 4 years old, now the child is 10 years old. They never thought about it or asked about it. That is why it is important when we encounter children where things are not adding up to go into the details of using a Bristol stool chart or asking the parents or asking the child to show how the stool pattern is. But these problems occur usually around toilet training and after that, and the children are able to usually respond. So if we do that, they'll be able to give us a useful input. So this gallbladder dysfunction plays a very important role, and VUR resolution rates closely correlate with controlling gallbladder dysfunction. And on the other hand, reflux reimplant failure rates closely correlate with non-addressed gallbladder dysfunction. So what are the treatment options we have? We can go for behavioral therapy, diet and fluid modification. They tend to take lesser fluids because the school toilets are not clean. They would like to avoid passing urine in the school. So they take less fluids. So they become constipated. And the diets are very low residue and they become constipated. So we need to modify all this to the extent possible. Advise and sensitize the parents so that they take necessary steps. And if they are on medications which are causing constipation, if that can be modified, then we need to go for that. Then quickly to look at the changes that have happened in the surgical interventions. We know that in younger boys less than 1 year of age, circumcision is likely to be of benefit. And more boys with breakthrough UTI and scarring the European arms as compared to the American arms, and the European children are more likely to be uncircumcised compared to the American ones. So probably there is a role in offering them, especially if they're younger than 1 year. And also, febrile UTIs are reduced by 57% with this Cochrane meta-analysis. So in those with the breakthrough febrile urinary tract infections, there is a definite role in surgical correction. But it certainly, as I mentioned before, does not decrease the risk of newer or progressive renal damage if there are no upper tract pyelonephritis episodes. So 3 broad groups of indications. The absolute ones are those who have a period of non-surgical management with breakthrough UTIs or patient non-compliance. So it's good to go through the checklist. Why there is a breakthrough UTI? Is it because the medication is not sensitive, or is it because it is not being given regularly by the parents, or is it because it's being given by the parents but the child is not taking, or is it because medication like cotrimoxazole are often out of stock and not available in many places, or is it because the child is developing some allergies and because of that they are not taking, or because the child is growing up, the dosing is inadequate, so do we need to change the dose? We check all these. We find that none of these are there, and if there is a breakthrough UTI, certainly there's a role in reimplantation. The negative one is those who have a high-grade reflux where the probability of resolution is low, and also if there are other anatomical problems like a large diverticulum or somebody who had a prior prior incision of a uretrocele where the reflux is not going to settle, the child is continuing to have UTIs, he can go ahead and operate earlier. And also if there is an impaired renal growth or renal function continues to be, the size of the kidney continues to be small. There are some controversial indications. We have been talking about this for a long time. One is girls who have persistent reflux at adolescence or puberty, because the argument is when they become sexually active, they may develop UTI. But the fact is that there are enough women who are sexually active who don't have reflux who have similar UTI. And there's no conclusive proof that the incidence is disproportionately more. So that's why this indication is a bit of a controversial one. Or if the parents or physician have strong preference to say, I don't want to give antibiotic, I don't want to see the side effects, potential this, that, so go ahead and operate, then there may be a role in operating. Then quickly to look at risk stratification. The high risk ones are, as I mentioned, the symptomatic male or female after toilet training with high-grade reflux, and to start with itself, the kidneys are abnormal with multiple photopenic areas. The management should, for moderate and low risk, whether they're symptomatic or not, toilet trained or not, if they have concomitant lower tract dysfunction or not, we look at one of the case discussions. And if they have renal changes to start with or not, high or low grade to start with, whether it was detected incidentally by a prenatal ultrasound, it showed some hydronephrosis, and then if a BCG was done, it shows a reflux, grade 2 or grade 3 unilateral, that will all falls under very low risk. So management will be far more conservative, given no prophylaxis, just close a follow-up with an ultrasound. So we need to consider the patient age, reflux grade, whether there's any concomitant bowel-bladder dysfunction, whether there's any scarring or not, and parental preference. These should be what. So these are the tenets that we understand now in terms of vesicoureteral reflux. We know that the reflux is just one factor, and there is a whole lot about the local milieu in the bladder, the antibiome, the immune response. Paradoxically, those with very strong immune response tend to develop pyelonephritis than with those with lower response. So the molecular studies in terms of the interleukin-6 response and other factors show some things which are completely opposite to what we understand. So reflux is just one structural parameter as a risk factor for UTI. In another 10 or 20 years, we'll know lots more factors, and we'll know that this is just one small fish in the pond. And also, reflux does not increase the risk of UTI being febrile and a scar formation after UTI. And many patients have these congenital lesions, which are more common in high-grade BUR. As I mentioned before, they might not have had any UTI at all, but in the high-grade concomitant dysplasia, they have photopenia, which are not causative of the BUR, but which are formed within the mother's womb along with the BUR, which is parenchymal dysplasia. And also, resolution of reflux has decreased the pyelonephritis rates, so we need to be following up on that. And many children with reflux are not predisposed to falling UTI as scar. So if they instantly detected grade 2 or 3, we need not be too aggressive on them. So to conclude, if I were to sum up in a nutshell, the first year of life is when the infant is highly likely to develop pyelonephritis, so it is safe to be on antibacterial prophylaxis, though there are several other discussions that are going on. And also, in all children presenting ages 1 to 5, CAP is preferred option of initial therapy if there is a high likelihood of UTI, or if they start off with photopenic areas. Definite surgical endoscopy correction is preferred treatment in patients with frequent breakthrough infections while on prophylaxis, or if they are not being compliant due to various parameters. And lastly, surgical correction will be considered with persistent high-grade reflux or older child presenting high-grade reflux. And also, we need to evaluate detailed evaluation for low urinary tract dysfunction should be done in all children where the reflux persists or worse in grade after toilet training. And endoscopic option is there for children with low grade of reflux where we can avoid an invasive operative intervention. Thank you.
Thank you, Chandra, for the wonderful presentation. Before we go into the panelists, we just need to say a few things. One, yeah, Karthik wants to say something out of the mic. Sure. Well, sir, you want to have some concluding remarks on Chandra's presentation?
It's a lovely talk here, but I would like to address the audience first. Now, beautifully spoken from an adult urologist point of view. I speak from 30 years of pediatric surgical experience purely. Seeing the child from the womb, most often with a bilateral diagnosed UHN and the newborn period. There is no difference. If you see here, I've been called here to speak of my experience and not to quote from literature. Okay, now bearing that in mind, if every child which is born with a fixed nephron, what do you call a complement, or what is that word? I don't know. Not reserved, there's another word. You have 1.2 million neurons per kidney for life. There are two, you are endowment, nephron endowment, that is the word. The second is the brain. You have fixed number of neurons and fixed number of nephrons for life or endo. That is why Sir was telling
like the kidney might be inherently dysplastic. If your nephrons are not good, then that is the problem. Now, it is our job as clinicians to preserve those nephrons, not when to say, okay, it's become damaged, I told you so. We should handhold the patients to end-stage renal failure or to a scar. If you can avoid, my job is to avoid that scar if possible, even before the first scar. I will not allow a scar to come. The problems are in high-grade reflux and infants, do you treat or not? They come to you for recurrent UTI only. If they are normal, they would avoid you first research. Now it has come with recurrent UTI for high-grade reflux. I have pioneered and I have been a votary for the past nearly 30 years of infant reimplants. I've had no problems so far. And here, surgery is being spoken of as though it is a big monster. Come on, we are surgeons. A ship was built to sail the seas, not to stay and rest at port. If we can correct it, many of you here, I see familiar faces who have assisted me or watched me do reimplants here. It is a 45-minute to 1 hour open surgery, a small scar there, and the child is fed within 1 or 2 hours, and the bladder drainage is only for 2 days. Sometimes I don't even train female infants. People here know it, especially those in childbirth. They will know. If the catheter comes, I don't even fix the feeding tube. I don't put the Foley. If it bites it, well found. Okay, so it is such a small outpatient surgery, and we don't discuss too much about it. If it is correctable, correct it. There is in Newsacon last month or a couple of months back, I put a slide about the water handle. Infant child is always lying down. Okay, the kidney is so close to the bladder, and the head of pressure is also there. I put a picture of a water hammer. So that is what it is, a jet of reflux going and hitting the kidney. So the damage is going to be permanent. The nephrons are going to be, if you can avoid it, then do it. And if you can do it safely, fine. It is like this, you know, the water source in your house, here, you're going to drink. It has been contaminated with the drainage, sewage. There are two ways to look at it. Pull out the, get a plumber, fix it, and drink clean water, or you can take potassium permanganate on your water tank or bleaching powder and have it lifelong. So each one is own poison. That's it. If you can correct it safely as an outpatient, do it. If you're not confident of doing it, do all this. That is my take on the whole thing. You cannot straight away say that, you know, all these review trials are all, if you see the median age is older children. Now, the kidney, the nephrons which you are endowed with, grow and mature only to 7 years of age. Meaning after 7 years, you can basically spit on those nephrons and nothing will happen to them. Further scarring, further thing, it basically doesn't affect their function at all. So that is why the management of an infant reflux is different from a older children with reflux. That is not addressed by most of these large-scale studies. They concentrate on the older children and say, okay, antibiotic in older child presenting 6 years or later, I don't generally treat the reflux. Just treat the UTI. And another thing which is not addressed in most of these studies is the pathology of the VU junction. Cystoscopic assessment of the VU junction is not at all done. Okay, you just blindly put them on antibiotic. You should rule out a parauretic diverticula, a laterally placed ureteric orifice, or a poorly developed rhino, where any amount of antibiotics are not going to cure the, or waiting will not cure. So you have to have a cystoscopic assessment. My concern here and my focus is not everything what he said is bad nutrition. Or my experience is otherwise. Infants with high-grade reflux with UTI require a plumbing to correct, prevent the reflux. It is within your power. Why do you want to wait on antibiotics and all that one? And it is a simple procedure. Older children where the nephrons have already matured, it doesn't matter whether you treat or not, you put deflux or don't put deflux, it doesn't matter. Okay, that is my.
Thank you. Yeah. Just to, I agree with your experience, but what we see is when parents who are compliant with prophylaxis, the number of children who present with breakthrough UT is very less. And how many of us encounter parents who come and say, somehow, doctor, please operate on my child? The default mode for a parent is, can you avoid an operation? And when that is possible scientifically, you should keep in mind. You finally take a decision, but then, it is based on what your perspective and what your understanding is and what the literature says. So that would be my take on that. Because if it were my child, if the child, okay, is a 1 year old, okay, had one episode of UTI, and then if I give prophylaxis for 2 years and then after that no UTIs, and I don't even do VCUG to check if a reimplant surgery can be avoided. That would be my take on it. But it is based on what our perspectives are. But I do fully agree in terms of a high-grade reflux and then unit, where the chance of pyelonephritis is high, then yes, should go.
Thank you very much, Dr. Chandra. There is a wonderful discussion between Dr. Wilms and Sir and Dr. Chandra. And Session is one side of it.
On the individual thing and how we go about that.
Yes, and also we have
layman and that's a small question. See, previously when we were thought, is there any difference in the treatment of reflux in a male and a boy and a girl? Do we differentiate? Okay, girl needs such treatment, a boy needs this treatment. Like say, we used to tell the girl needs definitely some sort of a correction for the reflex. A boy does not need. Is there any at present in present data? Is there any change, any difference in treatment for the boy and the girl?
So one is in terms of the circumcision. In boys, circumcision reduces the chance of repeated UTI. So even if there's a reflux, and then we see some parents who stop antibiotics for some reason. Child didn't have any UTI for 6 months. We don't do anything. The girls, there is more of a problem, bowel-bladder dysfunction, which is seen lesser with them. In terms of algorithm, earlier we used to think for a girl, persistent reflux should not be allowed to continue. But then that again, we see so many who are seen incidentally later with the persistent reflux, no problems.
That the chance of pregnancy with the reflex, any problem with the future pyelonephritis and other things. That was the concern.
That was the concern. The thing is now, the number of those without reflux developing pyelonephritis is similar to that. So how many times have we in the recent last 20 years non-operated reflux presenting with pyelonephritis where we bet ourselves on telling, oh no, we didn't correct this.
Thank you. Thank you.
Thank you very much, sir. It was a nice discussion there. Less than 7 years, go for a plumbing. After 7 years, go for a protection pump. But the word finally said was everything is a poison in itself. Thank you very much. Thank you very much. Now it's time for us to call the next panelist on to the stage. Before that, we welcome our Professor and Director of Nephrology, Gopal Kishan sir, for our program. We welcome Dr. Umapati or RMO for the program. And we have a few plastic surgery chiefs and colleagues who have come here. Dr. Sukumaran sir, Dr. Selvakumar sir for the program. Thank you very much. Thank you very much. And this program, we are having TNMC points, so we need to register to get those points. There are only 18 or 19 people who are registered so far. We already have some 70 or 80 inside. So I request you to kindly register for the program. Just a pre-registration, just have to fill up the forms. It's being circulated from behind. May I take the panelists for the next round? Professor R. Manikandan was former professor of urology, Jitma Medical College. To kindly come on stage, please. So they can kindly greet Professor Manikandan to come, please. Because Dr. P. Balamurugan from Mehta, please kindly come forward, sir. Thank you very much for accepting our invitation. Professor S. Saraswati, Associate Professor of Urology from Stanley Medical College, kindly be on stage, please, ma'am. And Professor M. Shivshankar, Professor of Urology from Savita Medical College.
Same continue.
And Chandra, it's okay. Thank you.
So welcome and thank you. I thought it'll be good to have some case scenario discussions, and then I'm sure from stage and off the stage, this is good to get perspectives because our perspectives widen and broaden. So just to give us an example, Sir was mentioning about 2 days discharge after a reimplant. But before I went to US for study leave, the reimplant surgery as such is a very major procedure where the child has a suprapubic tube, 2 splints from the ureters coming out, and then a catheter hanging for 1 week, and then catheter removal. And that is how it used to be, what I had seen. But over there, the experience that I had seen was you do a 3-layer bladder closure, 24 hours, you remove the catheter, till then the catheter is just in a diaper. So it's completely different mindset. So we do learn from each other based on our experience, and we know what we have done. So we would like to get your perspectives on some of these patients. So this is a 1.5-year-old girl who at the age of 1 year was started on antibiotic prophylaxis of cotrimoxazole, and the child was being given the antibiotic prophylaxis regularly, and at 1.5 years of age, she developed again a febrile UTI of 102 degrees requiring parenteral antibiotics. The DMSA scan did not show any photopenic areas. So what would be your thoughts on how to proceed with treating this child?
Sir, the female child was not been fully toilet trained, and on continuous antibiotic prophylaxis of bilateral grade 3 VUR with breakthrough urinary tract infection. So we have to go, as you suggested in your presentation, we have to go into detail to assess whether there's a bladder bowel dysfunction. Talk to the parents, understand the bowel habits. If there's a lower urinary tract dysfunction, focus on that, treat the lower urinary tract dysfunction. And the DMSA has not shown a scar yet. And the bladder is smooth walled, so there is no other secondary causes for VUR. And then treat the lower urinary tract dysfunction. Keep the child closely on follow-up. Probably after this VUR is the acute urinary tract infection resolved, maybe at 6 months later, we'll have to do a VCUG or a top-down approach to look at how the child is responding to the treatment.
Any other opinions? Because especially with the bladder appearance, it is smooth, but the capacity seems to be on the larger side, bigger capacity bladder. So the child is emptying, but then this whole concept of this cystopathy secondary to this reflux, where there is this large volume going back and forth. So what would be your opinion?
Before we get into the management part, I would like to qualify that whether the child was symptomatic with UTI or was it a culture proven UTI, just routine done routinely. Or
it is a fever, bulky kidneys, and 101 fever, and culture was positive.
And we will check with how the urine sample was collected. It is very important because we make a lot of our inferences and decisions based on the culture report. We have to ensure that it is collected properly. We have to insist on a clean cat sample. If a child can cooperate and can indicate. If the parents have to be educated, the sample has to be a clean cat sample and preferably the morning sample, and should be plated within preferably 4 hours so that we get the best information from the culture. Right. Then I would, before I go into the MCU, I'll also try to get more information from the ultrasound. Like you mentioned about if bladder looks normal, we want to see how much is the post-void receipt, because she could be not emptying the bladder completely. Partly because you can see some little people over there. Probably the whole thing is because of bladder dysfunction, which is resulting in significant retention of fluid. So that factor needs to be addressed. So I will try to get a little more information from the history itself to see what is the voiding pattern. Is the child voiding once in 1.5 to 2 hours? That's what we'll expect in this each, or the baby continuously dribbling. Shows that maybe she's got an overflow bladder which is continuously dribbling. Then also look at the spine. It's got a bubble. Under bladder dysfunction, look at the spine, whether there could be any evidence of this. So we have to try to find out a cause which can probably predispose to occurrence of in the bladder which otherwise looks normal. So I try to examine the child where to look for features of occult dysfunction, especially when they have bowel and bladder dysfunction. Get more information from the history and get information from the ultrasound to look at the post-void residue and see if there's anything which can be corrected. And other than continuing with the.
Thank you for those valuable perspectives. Madam, what would be your?
Breakthrough UTI is another indication for surgical intervention, but as sir said beforehand, I just want to know what is lower urinary tract. So how is the lower urinary tract indirectly by assessing the post-void residual urine by ultrasound, and also the bladder bowel dysfunction.
Yeah, thank you.
have been on the scene, say it's a grade 3, thinking that everything's whatever sir was explained, that okay, everything normal. It's a grade 3 breakthrough in the female state. So we have to continue antibiotic till the age of till she gets that all habits, toilet train, and proceed from there.
Yeah, and it is right that we started on prophylaxis, but on that, because she had a breakthrough with that, we ensured we checked the ultrasound. It was not like a lot of residue, but then in the non-toilet trained children, it is a little difficult to assess. All what we can do is we can check. And also with the clinical picture of pyelonephritis with numerous leukocytes, we take that the culture is representative of that, especially the bulky kidneys, and that's what we did. So we did treat the UTA, and then after that, because it is a young child, grade 3, and while on regular prophylaxis, she developed this, we went ahead and did a reimplant bilateral coherence. Any opinions from the floor? Yes, sir. What we did was, we did a bilateral coherence reimplant. And any opinion on this bladder, sir? Do you? I'm sure you encounter this kind of a big bladder often. Do you give any weightage to that bladder?
See, it's not comment on the capacity of the teaching this. Never comment on the capacity of the bladder on an HC. Somebody, if my postgraduate says that in a Viva, I will take a view of it because the capacity depends on the filling. You assume that he has filled it properly. Okay, capacity can be only assessed by directly by ultrasound, by UDS, or direct visualization systems. So I won't comment on the capacity of this bladder. If the bladder was capacious, I mean, you want to assume this bladder is capacious, then a cystoscopy and if necessary, if the ureteric orifice or papillus requires reimplant is the only logical thing. I would not go too much by the. I would like to have seen a post-void film.
Yeah. Post-void showed complete empty.
Then with this film, I will not. If the post-void film shows complete empty, what reimplant is the right?
So, what is your comment on the bladder size in those with a high grade versus intermediate grade reflux? In terms of when you do the reimplants, in these you mentioned about the infants.
Yeah.
So when they have a say grade 4 or 5, frequently it's a dilated urethra, but after you divide it, usually they don't seem to require tailoring.
This is a very interesting point. There is a difference between the ureter, the refluxing ureter, and the obstructed megaureter. In an obstructed megaureter, you cut the obstructed segment. It is very thin. It will in front of your eyes, it will shrink. Whereas refluxing ureter is hypertrophic. So if you feel that it requires tapering, please do it. Don't assume it's going to shrink itself because it's always going to be a problem in getting the Backwin's ratio. So you have got to tunnel it, right? So for that, I need a trim ureter. So I always trim in a reflux, even if it's an infant, high grade reflux, if it is very dilated, it will not come down. So you'll have to trim, I do the Hendrix trimming in a obstructive, in a reflux. Okay. Very rarely I've had to do a trimming in an obstructed megaureter, which I did 2 days back, Thursday in my department, where I had obstructed bilateral huge elephant-like thing. I had to trim both.
How old was that baby?
Oh, that's a complicated case. It was
Yeah. The thing is, some of
kind of 3.5 to 4 years old.
The older age we see the other way around actually. The obstructed megaUreters tend to be much thicker when they have been picked up much later in life. And there is another thing about,
say I'm a votary for early surgery for, I have, my lowest is 5.5 months at childbirth. But for obstructive megaUreter, I wait till 1 year of age. Somehow magically, because of those growth factors, the obstructive megaUreters, about 60% of them improve towards the end of first year. So I repeat the investigations at 1 year and 2 months, and then if it is still obstructed, I operate. But 50% of them improve by the end of first year. Thank you.
So I got a question. Yes. So you said that's a breakthrough UDA. So you said pyelonephritis.
Yeah.
So in that case, why don't you treat the UTI first?
Yes.
Then wait for 3 months. Go for a DMSA. If it is showing start, then we can operate.
Yes, just that when
like the factors that I mentioned before, if the parents have not been giving medicines regularly, or if the dose is not adequate, then changing those parameters will reduce the risk of further episodes of infection. But if they have done all that correctly, and over and above that, if the baby has developed a pyelonephritis, probably we are subjecting the baby to increased risk of further renal damage if in case the baby is developing upper tract UTI, pyelonephritis with concomitant reflux. Because we know that with the reimplant, the pyelonephritis rates come down. And if the pyelonephritis rates come down, the chance of parenchymal damage comes down. The chance of further acquired renal scarring comes down. So that would be the logic for it.
So that's totally different from what we 1.5 years, the diagnosis, all that is cannot be done. We usually try to push the reimplantation of 2 months. So that is intended for us to do this. That is mentioned, it can be done at 6 months as well. So what we do, the diagnosis we always do is, I thought we consider an endoscopic inhalation of bulking, especially in grade 3, you might have a little better response than in grade 4, grade 5. Second, if you still have to go for a surgical correction of reflux, I prefer a vesicoscopic, where you just don't have a big scar on the bladder. Because whatever is said and done, you have a scar on the bladder which reduces the compliance of the bladder by 10%. Every scar on the bladder reduces the compliance. By putting 3 ports, you avoid the big scar on the bladder. It's a little demanding, but it is very much good. So the other 2 options which can be done in this child is maybe an endoscopic injection of bulking agent can at least have a transient resolution of the reflex, prevent further febrile UTIs, and then try to postpone the definitive surgical correction. If surgical correction has to be done, vesicoscopy could be an alternative to open reimplantation so that you avoid a scar on the bladder, not in the cosmetic scar. Open scar is definitely superior. The scar on the bladder results in decreased compliance.
Certainly, options to be kept in mind. Yeah. Yes.
There are option of managing the bilateral implant. Then it's a filling reflux. In my mind, when I saw this issue with filling film, I was just thinking whether it could have been a large diverticulum also. Was there any diverticulum?
There was no diverticulum. Yeah.
That's fine. The prostate reflux.
Yeah.
So, option wise, that is fine. Just one query that you do any contract study for that?
Yes, we had DMSA. Both no scars to start with, yeah. But definite pyelonephritis at very high CRP, 101 fever with bulky kidneys on the ultrasound.
There was a clinically extended bladder also.
Beg your pardon?
Clinically extended bladder.
Clinically, it was not. It was a normal therapy. As sir rightly mentioned, filling can over distancing can.
The filling
more delicious. I would take. I would be concerned if a PG tells about a smaller bladder. On a VCG, if it's a small, if he says it's a small bladder, it may be due to underfilling. But when it can be filled this much, we know that its capacity is at least this much.
The rule for our postgraduate says filling reflux is always more dangerous than avoiding reflux. It's a resting reflux.
Yeah. Shall we go to? We have time for one more, Dr. Sengel. 10 minutes, yes. So we'll go for the next one. I have a full pack for the whole day. So this is a 15-year-old girl who presented with recurrent episodes of UTI. Unfortunately, she was being treated on and off with febrile with antibiotics for febrile episodes without any further evaluation. And she did have some bit of incontinence and some constipation. No nighttime incontinence, daytime incontinence, and this is the voiding film, and that is her DMSA scan. And the creatinine is 1.4. So, what are your thoughts on the further treatment and evaluation of this girl?
I think this child with symptomatic significant reflux, with a small capacity, little irregular bladder doesn't seem to be distending out of the pelvis.
probably a high pressure non-compliant bladder is the reason why the reflux is persisting, and she's got febrile UTA, and she's getting scars with azotemia, with rising creatinine. Definitely, we need to address that. And of course, she's also got bowel dysfunction, so I will still keep the spinal component, the spinal component in mind. Still, I think, irrespective of whether there is a spinal cause, the bladder needs to be stabilized first. So she is going to require correction of the reimplantation, but more important is trying to correct the high pressure bladder. A video urodynamic study maybe will help us to get an idea, gauge an idea about the compliance status of the bladder, because once it starts reflecting, we may not get the actual compliance. A video urodynamics might be a little more informative than simple plain urodynamic study. So I would plan and trial anticholinergic therapy if she had not already been done. But keeping in mind it can worsen the constipation, I'll try to use agents which are very selective. Tolterodine or mirabegron could be a better option than oxybutylin in this child. Give a trial of anticholinergics. Try to institute CIC in this child, so female child.
Female.
So that we ensure that she is emptying her bladder completely. So the meantime, as we give a trial, the medical management to distill the bladder, to relax the bladder. So we also ensure that she empties her bladder completely. We can treat her CIC, or if she can be kept on overnight catheter drainage, so that the chances of UTA, which happens maximum during the stasis in the night, can be reduced to a significant. In the long run, definitive management will be, she might require a bladder augmentation in addition to reimplantation. So the bladder is very small.
Any other thoughts, madam?
First, I just want to know the post-void residual urine.
Yeah.
So accordingly, we have to.
She is emptying completely. It's not much. The only challenge when we were talking of this urodynamics is with such high-grade reflux. When it started filling up the upper tracts, the compliance is not reflective of the actual bladder. So we did have a study which did not reveal any poor compliance, but looking at the bladder on the VCUG picture, we know that clinically this is not an innocent bladder, which is a treacherous bladder. So any opinions on these kind of bladders with high-grade reflux to interpret the compliance bit of it, so that needs better? Because if we do only the reimplant now, you have to come in again for an augment. But if it is a frank voiding dysfunction with a concomitant poorly compliant bladder, it is better to do everything in one shot. So how do you decide on that dilemma? Any opinions? Yeah, so now we know from the bladder appearance that it's a thick bladder, but the video urodynamics did not reveal that poor compliance because it started refluxing. So do we reimplant alone or combine it with an augment, or how do we proceed?
Looking at the VCUG picture, the cystogram phase, definitely the bladder capacity is small for our age, with a kind of high-grade reflex, with the dilated tortuous ureters. We definitely, when we're going for a definitive surgery, the bladder is expected to be thick-walled, small capacity. So the decision has to be open-minded, because definitely video dynamics will not be truly a representative of the bladder dynamics. So when you're planning for a, say, ureteric reimplantation, you might tailor the ureter to reimplant in the thick bladder. So augmentation has to be kept as an option, depending on the intraoperative findings. Definitely.
The high pressure bladder, if you're going to reimplant, you're converting the reflexing system into an obstructive system, which could be more detrimental to the
Yes, those are the dilemmas in this which I wanted to discuss. Yeah.
Treat UTA and then maintain like time void SARS to know the functional bladder capacity, and then can give a trial with anticholinergics with a close monitoring that she is not going for constipation or increased PVR. And then we can take a call on further management.
Increasing creatinine, I think we need to step in.
Yeah.
So short period of medical management to relax the bladder, always plan of augmentation with reimplantation.
Any other opinions? Yes, sir.
The basic point is it a neurogenic bladder with secondary reflux? Or is it a concomitant reflux and a neurogenic bladder? So when there is a high pressure bladder, we definitely have to address that first. The point to be taken to is whether we are going to reimplant at the same sitting. If you are going to just put up on medical management, I don't think it will improve. It has to go in for a surgical decompression of augmentation. So when you augment, you reimplant. What is the age of the patient, sir? 15 years.
15 years.
15 years old. In a 15-year-old child, you have to do a non-reflux procedure. Or can you just augment the bladder, leave it, and watch?
Yeah.
Because the point is, the scarring may not be much after 15 years.
It may not happen, but already it's, with the creator 1.4 and those images, it's already a fair bit of burnt out.
The problem of putting it in a thick pore bladder is once again the obstruction.
Yeah, that's true.
The complication of obstruction. So, how do you go about it?
Yeah. Any other thoughts or opinions? Cystoscopy grossly target-related bladder. And the capacity, like average capacity.
Difficult case, as Bala said, you don't want to convert this into an obstructed system. Straight off, I will put it on propan, wait for 6 to 9 months, see things improve. And you said it is trabeculated, you are sure the compliance is good. Why don't you, it's 15 years, the kidney function is not going to improve anymore.
Correct.
You just want to avoid further upper tract damage. You try to relax the bladder, you can put Botox in one. As much as you can do a trial of Botox. It will relax the bladder with the all. And
PSS after that. Yeah. Would you start, because in the HCA I mentioned that she does have avoiding dysfunction, some incontinence, and with these changes, would you start her on CAC upfront with the concomitant medications that you had advised? Or would you continue the spontaneous OAD?
You see, CAC in females is very, very difficult for intubate, though, especially with the sensitivity. And a males, in my experience, it's actually easier to do CAC. He is able to guide the tip of the urethra, right? A female, it's easier said than done to do a CAC. How will the girl child do a self-catheterization? That's pretty difficult. So I won't take CAC as a thing. Neither would I suggest the Nicky button, which is suggested for these cases. When the bladder wall is bad, why put a button there? Yeah. So you try somebody here said, Madam said, a trial of propan or anticholinergics. If it doesn't work, or if it works only partially, and if the bladder is trabeculated, some of them have got good experience with Botox injections. I think single presented such case recently, a couple of cases recently. So I think that is though it's costly, that is also, we have to explore options to relax the bladder. And then augment will be the last.
Yeah.
Especially when you're not able to prove it on a urodynamic. How will you sell it to the bladder?
So what we needed to highlight in this is just not the refluxing ureter which needs a reimplant. There are other concomitant issues which need to be addressed before taking care of the reimplant. That's the point we wanted to highlight on this case. We'd like to thank again all the panelists and the Chennai team for inviting me. Thank you.
Chandra, please stay on. We need to list.
Thank you very much, Dr. Thomas. Excellent presentation, excellent discussion by the panelists. I thank you all very much. I think the piece benefited a lot. A lot of things to discuss in this, but I think what was done has been perfect and very nice. Please.
Thank you, Dr. Chandra. Thank you, Dr. Manikandan, Dr. Bowel-bladder, Dr. Saraswati, and Dr. Shishika. Thank you very much. It's time for us to felicitate our honorable the program. It's a time down the rest of the second.
Sincerely thank our RRM for this invitation and encouraging us for this. Thank you very much, sir. Thanks after your busy schedule, you're coming here, sir. Thank you.
It's time to spend just a few minutes for Professor JVS sir here. Professor JVS sir, may I request you to kindly come to the stage. It will be so nice if our seniors can join Professor JVS sir, who is superannuating another week's time. Sir is about to retire. May I request our seniors to kindly come to the stage, please. So, JVS sir. Simply wait, sir, please. The day itself takes a very small time to state the Prakash sir here. Because on behalf of everyone, Professor Shivshankar sir, to kindly present the floor of Professor JVS sir, please.
Very well done, sir. Balasubramanian sir. Hari sir. Hemlata madam.
We can request Dr. Saraswati ma'am and Dr. Arasi ma'am also to join because we have been a part of JVS sir's team all these years, please.
Yeah, we will have.
Postgraduates.
Postgraduates to kindly join on the stage before we go to the next session.
Please round it back.
We have.
Postgraduates. இதானே
Thank you, Rob. Thank you. Shivashankar, Director in Shivashankar. I want to do one announcement regarding the medical college. Next month, in July, I'm going to pay up on service. So we are planning a CME on 18th at Kilpaw Medical College. And in that, one international faculty, Nandirajan is coming, and in our faculty is also coming. So it's a provisional invitation. Kindly all take for CME. And I will be very happy.
Yes.
Thank you very much. We are going to take just a few minutes behind schedule. RC Madam next from the very formal request. Yeah, please.
The robotic surgeon, Dr. Nambirajan sir, is coming from UK and he is willing to train a lot of connections. Thank you for station also. Pediatric oncology. It's a please for a big come and get introduced.
So we had an opportunity to be with Dr. Nambirajan in the 1995, 96, around that time. It was fantastic time with Dr. Nambirajan. He was young, energetic at the time. The way he holds the scope with so 2 years old, later he holds the scope on the other side. Anyway, we have an idea of who to party us. We now go to the next session. May I request Professor Wilms to kindly come for the session first.
Yes. No. That's camera.
Yeah. That's okay. Can I start?
Yes.
Go back. Yeah. No. In the presentation, we are talking of whether single stage repair. Single stage. On the panel discussion.
In the PV. Duplicate. Yes, yes.
Yeah. Good afternoon. At the outset, I thank the organizers, specifically Professor Shivashankar, a long-term friend of mine, for extending this invite to be part of this discussion. Life has come a full circle. I am from this institution. I did all my education here, MBBS, MS, and MCH. And it's a coincidence probably that the person whose retirement we are celebrating, or Prakash, was my MS batchmate at Madras Medical here. And I became, incidentally, a Madras Urology Society member in way back in 1987 as a final year, when Dr. Jairam and Dr. MGR sir, all of them were active here, Dr. Vijay Shankar and DC. And life has also come a full circle regarding hypospadias. When I trained in the early 90s, and the hypospadias were a horror world to surgeons. We had, it was a world full of strictures, fistulas, breakdowns, scar penis, suprapubic diversions, calibrations, catheterizations, and whatnot, and recurrent everyday bronchitis. It has come a full circle today. There are people who have worked with me in ICH who have been posted here. There are people who have assisted me, young consultants. We know that hypospadia, at least in my hands and in my unit at ICH, fistulas and breakdowns and redo surgeries or calibrations are something very remote. Sometimes our PGs don't even get informed consent for that. So life, it's a very happy to see all this in my lifetime. And what has worked well for us, I will share it with you in the next few slides. The technique I did was, when I finished my MH and ICA and MFC, and then I went to Stanley for a year on the advice of a urologist. Again, my cousin, Dr. Vijay Shankar of Madurai, he said, Ade unit la continue panada. So I went to Stanley, and I had a chief, Professor Jayachandran, who really encouraged me. I wouldn't, not technically, he said, do whatever you want, well, I'm here to back you, your hands are good. That made me try out various techniques, and I serendipitously found this. Those were the years, 1996, and my colleagues in Pediatric, I was a pediatric surgery assistant professor. My colleagues in urology were sitting here, Jai Ganesh, Perisami, Thiruvarul, and Muthu Veeramani. With DC as the chief, we used to share a theater also way back in 96. And that work in Stanley, I first published a series of 28 cases of continuous proximal hypospadias, where we had only 4 fistulas. And then in 1997, when I came back to ICH, I was allowed to do these things because they would say only 2-stage repairs for proximal hypospadias. So I was allowed to do single-stage repair, and this is what I have been doing right, only one technique since 1996. As I said, I didn't have internet access to thing. I didn't realize what I was doing was a modification of what Asopa and what Asopa was doing. So what I basically do is a double phase. I wanted to do a preputial flap. To call it laziness, I'm a fast surgeon. So I try to take the dorsal flap and one go, both the cover as well as the tube. That is my technique, double phase transverse preputial flap. Now, this has given me surprisingly good results, not only in my hands, and of late, the past 10, 12 years, my unit in ICH and a couple of others in my department, they also have good results. As I said, fistulas and breakdowns or redo surge are pretty rare. If you see the S1 list, in the first 6 months of this year, we had only 1 fistula repair and probably 2 last year. So that is how good it works, provided you follow the basic principles. And so it is not only good in my hands, it is reproducible. Reoperation less than 1% of cases. That is fantastic. So when do I operate? I'll come to the technical aspects later. The time of operation has got a lot to do with it. So I operate at 1.5 years of age. A lot of children are born and they book their time at 1.5 years, because at 1.5 years, the child doesn't basically have cortical control of his maturation. I want it to be an automatic bladder. The biggest problems occur when an older child, you do a hypospadias, a beautiful hypospadias, it voluntary controls maturation, and you have a fistula. Because of the possible perceived pain the child might feel, it looks at its penis and tries to control. A child below 2 years, has no, he doesn't feel the cortical, 6 fixation occurs by the end of 2 years. So till then, a child will be roaming naked in the house. If you have seen children, and they start hiding behind pillars and furniture only around 2 years of age when a stranger comes into the house. So you do it at a time when the child doesn't realize it's a male or a female. It has no memory for remote events. So at the end of your repair, when you pull out the catheter after 1 week, it voids freely. It doesn't feel that somebody has done a major procedure on it and it has to control the maturation. So that solves most of your problems. So I do it at 1.5 years. Investigations are simple. I just do an ultrasound, urorenal problems and a coagulation profile. Believe me, I have found out a lot of coagulation problems in my time. All of these problems have happened in private child trust. One, factor 13 deficiency, factor 9 deficiencies, hemophilias. In all these cases, you'll find out, coagulation profile prior to surgery. These factor 13 deficiency, in another case, I didn't find out. I mean, the PT, APTT were normal, but the child bled from the catheter the day prior to removal. So always be worried, because it's going to be, your hemostasis had to be perfect in such cases. The role of testosterone, I will go into a little controversial things. I don't give testosterone at all. I don't believe it works. Testosterone causes a temporary improvement in the size of the penis. It makes it apparently simpler to operate. But then testosterone has lasting effect only when it is timed with the LH natural FSLH, LHFSH surge. That is less than 3 months of age, at 5 to 6 years of age, and again at adolescence. These 3 peaks, only if you time your testosterone with that, either injectable or local, will you have lasting effects. So these are outside my range of surgery. So I don't give testosterone at all. Second, the people I have seen give testosterone during surgery, the tissue, if you see on magnification, the tissue is so edematous, and it is so dangerous to operate on such tissues. Definitely they will have a fistula or some problem in such cases, which has been my experience. I've seen my colleagues use testosterone and the results are not good. So this is what I perceived, and I never used testosterone, either injectable or Serenase oil. Then anesthesia, this is a long way in improving my results. It is nothing like you operate, put a catheter, send them home with a catheter. I keep them in the hospital for all the 7 days. The child is put on a caudal epidural catheter with a pump, which goes in for 5 days continuously. That is why all my private cases on child trust and an ICH post-operative ward, we need a epidural analgesia at all times, and GA on table. It will be a GA with LMA. Never ever give spinal for adults. There are a lot of adult hypospadiologists here. Please never attempt to do a penile surgery under spinal. You'll have an erection, and I don't know whether Jay Ganesh remembers an anesthetist. I went to do a 28-year-old male in Roypeta, and before I entered the theatre on Professor Saravanan request, before I entered the theatre, they had given spinal, and throughout the surgery, I struggled with an erect penis. I think Dr. Jason was assisting me. So this was in 2000, yeah, that floods the Munadi, 2015. Okay, so don't give spinal, give a GA with epidural and IV antibiotic on induction. Okay, now coming to the technical aspects. What is important is you mark well. So when I will freeze the frame here, can you see this is, I've selected from my videos, real proximal hypospadias, which is here. This is a hypospadias. How is the orifice? The orifice is usually stenotic. Here, did you see it is white? You should be worried if it is white, because it is not just this thing. This is a perineoscrotal pseudo-vaginal hypospadias. The more proximal it goes, this is a pseudo-vagina. And such cases will have a Mullerian remnant, will have a prostatic utricle. You should anticipate problems in catheterization. You should be happy if you see this. So it will have a severe cardi. My approach will be to, I will try to, this is non-hair bearing. I will incorporate this non-hair bearing pseudo-vagina into my repair. I get about sometimes I get even up to 2.5 centimeters on that. And then this will be the cardi. I'll have to go in and remove all cardi tissue, ventrally, distally, under the glands, on either side. Here it goes almost up to the anus. There's a split scrotum anus. All around the cardi is all around. The spongiosum, which is not which doesn't back a urethra, splays around and becomes and contracts all around and causes a cardi. You will have to release this. You will see me doing that here. Sorry, I should not have paused it. Yeah, let it go. Yeah. I'm marking it. And this marking will go around the penis. And then I use adrenaline. Okay, now you'll notice that I will not use a tourniquet. I've never used a tourniquet. I don't believe in it. And you will see the operating field just now without a tourniquet. This adrenaline helps my more than the adrenaline, it is the tumescence which helps me. Yeah. This is important. See, I cut. You have to be careful here. You shouldn't open the spongiosum. If there's problems in catheterization, you have to double catheterize. Rarely you might have to do a cystoscopy and get a guide wire. As I said, no tourniquet is used. Cardiac correction has to be very meticulous, fully. And I am a surgeon who believes in planes and feet. I ask my assistant to stretch the glands. And then can you see I'm getting down on either side of the pseudovagina. This is on the left side. Dorsally, the buccal is exposed. You'll have to just use diathermy once to get the transoscopic feed. And this is the proximal, see how thin it is and how close it goes to the perineal body. Okay, you'll have to release this from this layer. It bleeds sometimes, but you should get the spongiosum out like this. Only then you'll get a good repair. It should be backed by good spongiosum here. Okay, and you should keep it well laterally for that. After removing the body tissue here, can you see many people when I started doing this were horrified. Who is he opening the glands like this? See, it's an avascular plate. If you stay on the corpora, can you see that? It is absolutely avascular. There is no tourniquet. Can you see that? That's a corpora, glands wings. A proper glands wings and a proper meatus can cover all sins below. You can do any amount of surgery. We have a white glands, a well-made glands wings. Can you see that? How I'm raising those glands wings? You will have to catch only a few vessels with bipolar. And then this is important. See, that pseudovagina, the length was too much. So I was tubulating the pseudovagina for a little distance. It will gain me about 2 centimeters, I think. And I use continuous non-locking PDS, 60 PDS for many years now. But then what I have realized is the suture material, I have gained about 1.5 centimeters. Okay, that's a lot when you are thinking of distances in children. Yeah. So I have got 1.5. I have to measure from there to the tip. This is what. So now I need a 5 centimeter long tube, which is pretty long. I mark it on the dorsal preputial region. 5 centimeters. I take a rectangle there. Can you see stay stitch here, stay stitch there? A composite flat is taken. I don't try to separate the tube from the cover. Yeah, I mark it and cut only the skin. Separate the dorsal skin away. Yeah, I cut it there. Separate the dorsal skin and take a vascularized flap and mobilize it. This is the vascularized flap. This is the dorsal skin and the inner preputial skin. This is taken to the right or left. I usually prefer it on the right, and that will be the tube. Okay. I started creating the tube up till here, and after that, it will become I am fixing one part of the. I used to use a caliper. This was probably taken in 2016-15. I stopped using it for 6-7 years now. Because the calipers and childbirth are people. So I measure from this to this. This will be the inner tube, or it can be the onlay. If in case you have got a good urethral plate, you can use it as an onlay. and then I curve it inside because, I have to cover for this length also. If I keep it too loose here, why? So can you see I'm narrowing it here? It will cause eddy currents there and it will cause a fistula. So I keep it snug at the point where the native urethra meets the tube. As I said, I use currently for many years now, I'm using the 60 PDS running non-locking stitch. Then you see the one edge of the, both edges of the tube are taken and fixed to the corpora on top, so that the anastomosis goes partially and it is covered by the tube. It goes all the way to the top. And fix it to the tip of the glans. Professor Shiv Shankar wanted me to put an operative video. I don't know why he insisted that. That's the reason I edited this and brought it here. As I said, this glans is approximated, fixing it to the meatus, the tube there. And I try to create, all of you, as there's a lot of assumption among hypospadias, you get a round meatus. All of us have got a vertically slit meatus only. Okay, which is more ventral. There is no point in creating a perfect round where it can get stenosed very easily. And to tether the outer skin. This is very important. Now, I have taken this tube right up to the top and then I create some space there. This is a double phase. This is a composite flap. I try to bring that side and fix it so that, the flap doesn't slip there or there is no tension on this anastomosis. See, that's a long anastomosis. I fix it to the corpora on the other side. Somehow the projection clarity doesn't match the video. I'm sorry about that. This anastomosis goes well into the scrotum, if you can see. See, you have some supple, loose vascularized skin here over the anastomosis. So God forbid you have a fistula, you'll have a lot of vascular tissue there to do the fistula repair much later. Fistula or stricture, you have so much of vascularized skin. See, such supple vascularized skin on the ventrum. Sorry for the spelling, it's a penoscrotal transposition. So I cut down, you have to bring down the scrotum all in one stage and then take the central bit of scrotal tissue so that you get a good scrotum. Bring down the scrotum. And deconstructing this median raphe of the scrotum. So from no penis, now we have got a good length of penis. Okay. And I have just kept a simple periurethral catheter, a feeding tube. I usually use 7, 8, and an older boys 10, which I rarely get to do nowadays. Most of my children are less than 2 years. And you notice that I put only continuous stitches even for scrotal and penile skin. People know that even for circumcisions, I use continuous stitches only, non-locking. It works very well. This is the end result. I got a good length of penis and a scrotum which is down. I use a 8-inch PVC feeding tube. The dressing is something which I do myself. I don't leave it to any assistant. I don't do compressive dressing at all. It's a simple battigrass followed by just a micropore plaster, fixing it on all layers. I fix the tube dorsally so that it doesn't press on the anastomosis or the flap downstairs. It's a 4-point fixation. We fix it to either side of the scrotum. I take the stay stitch and anchor it there so that I can use it for a dressing. I remove it only after 7 days. I don't do dressings in between. I remove the catheter and the dressing straight off at 7 days for all my cases, irrespective of the length of the anastomosis. it's important to cover the dorsal loop. Child will put a finger and pull it off. So it's important to cover that. Post-op analgesia, as I said, I use a continuous epidural bupivacaine infusion for 5 to 6 days. It's important to relax the bladder. You've got a catheter inside, so I give Tropan for all children for 5 days. I remove it 2 days prior to catheterization. Bladder is catheterized for 7 days, and dressing and catheter removal one go at the 7th day. And usually in my cases, around the 3rd or the 4th day, there will be a pericatheter leak, which I welcome. That means the edema is coming down. It has been my observation when I was very young, when there were SPs and you fully divert the urinary stream, somehow the urethra doesn't heal well. I believe, I cannot prove that urine has got some growth factors, and all the cases which there is a pericatheter leak, I'm happy. The edema has settled, and I encourage it. I just smile at the patient. Very good pericatheter leak on the channel, so that the child is used to urine coming by the side of the catheter, and it voids very well when you remove the catheter. The biggest problem is at catheter removal, the child, older children about 2 years, they scream, they look at the penis, and they stop voiding. So what are the parameters I follow? And it's important that, many of you would have been aware who have worked with me that I don't do any calibration. There is no need. There's a big meatus. All I do is observe the stream. I usually ask the patient to send me a voiding video. I look for whether the cardia has been fully corrected. The stream, especially in older children, you can uroflowmetry. My assistant Rohit Gopinath is presenting a case series of uroflowmetry on all the proximal hypospadias done in the past 5 years. We'll present that. Post-void residue on ultrasound. Cosmos is very important. An adult male spends more time looking at his penis than at his face on the mirror. So, all these are, should be done with absolute caution. And these are plastic surgery procedures, and you should take more interest, because when I was young, again, hypospadias used to be the 2nd or the 3rd case on the list. I made it a rule that hypospadias, especially proximal hypospadias, will be the first case on the list in ICH or elsewhere when I operate. I do it early morning at 6 o'clock in my private practice, because that is when I never do a hypospadias in the afternoon. You should be on top of your game by operating on somebody else's penis. And then potency and sexual satisfaction for fertility. If you have operated as long as I have done, I have patients who are 34 and 37 who I have operated coming back with their children. So I ask them about their potency. I have messages from, there's a patient in Hyderabad who messaged me last week also. The problem I have seen in such cases is the more proximal the hypospadias, such patients have a poor semen quality. They are abnormal forms, all of that. I have been seeing it regularly, that those with the pseudovaginal perinestotal hypospadias have got poor sperm quality, they have got problems with infertility. I have also had an occasion to do a scoping on these children. Some of them, they imagine somebody, an adult urologist, just says a hypospadias patient has some dysuria. They suddenly do a voiding thing and say they look at the membranous urethra. Even normally you will have a small stenosis. They will say that, that there is a stricture, you'll have to undergo a scopy. They come back to me. I've done scopies. Luckily, I'm sorry, I didn't get those films. They look absolutely normal. Many times you're not able to distinguish between the native urethra and the tube which I have done. So that is one thing. And as for, and no hair grows there from what I have seen so far. In my experience of these cases, many of the, there is a my numbers were worked upon by adult urologist, Danny Darlington. People from Stanley would know. He's now in London. He studied my cases both from Childress and ICH, and we got some numbers. And so far, I have a list of my thing. In all the few thousands I have done, there are only 13 cases of fistula, both in ICH and in private. Okay, all the 13 cases, I know what has happened. And there was a case of complete flap breakdown. The lateral part of the flap came off in a case in ICH. And a stricture in one case I operated in February. And sometime in May, the patient came back with, in April, they came back with a post-in. I wanted to do a scopum and check. They didn't believe child urine passed by May, it went into a full-grown stricture. Whether it's on injury, I don't know why. I think Muthu Veeramani also saw that case. So that is stricture. These are the only problems I had in all these years. So the takeaway message, double phase preparation, it's versatile and reproducible. I do it for all repairs, right from the corona down to the perineum. And that's why I call you can adjust the length, you adjust the tube size, and it's very versatile. It gives you a lot of vascularized flap ventrally to cover for as an insurance to future problems. It's technically demanding, yes, but then what surgery is not, but it's so rewarding to me, yes, pass out of satisfaction monetarily to the patient. It is technically, it is like yoga. So if yoga is mind control of the body, doing a hypospadia single stage repair is the absolute form of, highest form of yoga. So almost no complication and excellent long-term results. Yeah, this is my institution, ICH, the new OPD block, to which I owe all my experience to and my results. Thank you so much. Yeah, I finished in time. Any questions on hypospadias?
So we saw you injecting adrenaline in the beginning. And what we have been taught is penis is the end organ, so you should not be injecting adrenaline in the beginning.
See, I won't see what we have taught is without adrenaline, I don't think I would have got these planes. And adrenaline, both, if you say government adrenaline doesn't work, child trust also use it. So it gives me a good white feel to give me the space. And I don't think penis has got a fantastic blood supply. It's got a beautiful venous drainage, a double arterial supply, and it loops around down. And we are not giving into the penis. We are giving around the penis. You think the adrenaline is going to cross the buccal fascia and act on the deep arteries of the penis? No. Or the cavernosal blood supply? No. It cannot. 1 in 200,000, sir. I take a 200 ml bowl of saline and put 1 ml there. It becomes 1 in 200,000. I use it only for injection and not for mopping during the procedure. The tumescence. And to Prakash's concern is very valid. But then experience has taught me that nothing happens. I remember Bhakti sir shouting at me when I was giving, Bhakti sir shouting at me. He did the same when I was using bipolar on the penis. That's also an end organ. I use bipolar. You saw me using bipolar. So it doesn't actually matter. We'll have to get out of this old thinking. And one thing I always pride myself upon, I do not allow literature and published material to interfere with my education. You do and see. I don't think I was doing anything very adventurous on thing. Penis, the blood supply is from the deeper parts. Unless you go tie off the penis, using a tourniquet is much more dangerous. You can cause a spasm of all the vessels there. So I feel adrenaline is safe. It's been safe in my hand so far. My unit uses it also. Yes, Kapil. Kapilan asked the maximum notes on this.
During the glans approximation, sometimes the glans are poorly developed. Do you find it difficult to bring the glans?
No, sir. No. See, the problem is, the answer is in your question. Do you try to bring the glands together? No. I try to approximate the glands to the meatus on either side of the meatus. If it is hypoplastic, so be it. I will just bring the ends, hypoplastic ends, and fix it to either sides of the meatus downstairs. If it comes together, fine. Or I'll just restrict myself to that edge. It is like a notion where we have to bring it right to the tip and all. It is not necessary. You saw me dissecting. Initially, it looked so bad. When you dissect, it doesn't look. Don't go by impressions of an open glands. You open the glands and see. And this is such a small child, 1 year, 5 months. You've got such a thing. Imagine doing in older children. You'll have very good glands. This hypoplastic glands is an observation you see before cutting. I never used any definitions like urethral, plate size, all that, like Snodgrass does. I believe Snodgrass is a bad operation. So I never measure all that. It's all visual. If in an onlay, if there is no cord, if there is a ventral strip, good urethral strip, however thin it is, even it is 0.5 centimeters, I can adjust it to the tube. When I can very well make a tube, why can't I make an onlay? That 0.5 centimeters on the
DOS and Miss godsend manna to me. I will use it, suture it on either and make it a tube. Yeah, that is why your literature books should not be used as it's used only as a reference point. I tell my students, your textbooks, especially operative surgery books and your journals and all that, should be given the same importance as you would do to your car manual. Do you read your car manual when you buy a car? No. You open it only for troubleshooting. So when you have trouble, go and open your operative surgery book. Go check your YouTube. Go check your thing. But things going well. Why repair something which is doing well? That's what you do to your car manual or TV when you buy a new TV. Do you actually open your iPhone e-manual which they send? You don't. Same way with you don't your mind should not be cluttered with or restricted by advice of others.
Thank you, sir. Now, call upon the panelists for the next session. I call upon Dr. Balasubramaniam, Institute of Urology, to welcome our panelists. Professor R. Jayaganesh, sir. Professor Elizabeth, sir. Dr. Madhu. Dr. Gurunath.
Before you start, what is the minimum age you select to do the hospital repair?
1.5 years. Sometimes, you have these NRA patients, Dubai, June, July, August is Dubai time, vacation time. So they'll come at 1 year, 4 months. I do it. But usually I start at 1 point.
Did you decide to stage it?
I have never staged it so far. Never staged. I did it in 97, sir.
When you decide to stage it, I know he never staged.
He has seen me operate, Sir Shankar. I never stage even if it's perineal. I was once forced to 1997 or 98 by K.J. Vivekanandan, sir. He had to abandon a procedure mid-meeting, go for a meeting. I had to finish that. But basically, I am against staging because the retubulization, if you look at the fistula rates and imagine an open thing, a child has to leak urine from a lower orifice and the fibrosis.
I have just one request, because I do fully stage always. But in adolescence, we do see a good number of children who have had a single stage operation who have tethering with the skin. Now, I'm not telling it happens to everybody.
Tethering where, sir?
The skin which is put as a single stage tube causes like a bouncing effect.
No, I can't see when it is fully released like this, it won't happen. See, I cannot vouch for everybody's technique.
My request is if you can please get the long-term data, because the whole world is talking.
So I am talking of 30 years thing. I will give you the data.
I'm not telling about experience. Telling the whole world data talks something different.
That is why, sir, I should not be restricted by that. I should go only by my experience, and people who have gone through my institution, both Child Trust and here, they have been following this all these years, and it is reproducible.
You can make it known to the world. People think the other way around. They'll understand. So that's why.
Yes, sir. Point well taken. I'll present this.
The proximal Vesicoureteral, all this is really evaluated for intersex.
Yes, sir. See, you suspect, very good question. I think there is another presentation. When both testes are down, they are testes. It is a male. There is no need to investigate or do a karyotype at all. If one testis is not there, and if that side scrotum is not well developed with the proximal hypospadias, yes, you have to do a karyotype. What can it be to the youngsters here? You have only one testis down. You have a poorly developed scrotum the other side. Ultrasound shows a Mullerian remnant. Mixed MGD, mixed gonadal dysgenesis. You will have a XO, XY karyotype,
And there we look at 50 metaphases and find out which is prominent. But when the testes are descended, even if it's a perineal hypospadias, perineal scrotal pseudovaginal isotroph, there is no sanction to do a karyotype because it's a male. Ovary, there are some rules. I think I will share it. I presented somewhere which you won't find it. There are rules in DSD. DSD is disorders of sexual differentiation. Testis, my first rule is testis descends. Ovaries do not. Why? Can anybody say why ovaries do not descend? They are restricted by their ligaments. You will never have a fully descended ovary, you will not have a fully descended over testis either. So, if the testes are palpable, any gonad which is palpable in a labioscrotal fold is testis. It is not ovary or over testis. Over testis will have some degrees of maldescent. If it is fully descended, it is testis, and you should assume it is a males.
Thank you, sir. We'll just move on to the panel discussion on PUG obstruction. We have 15 minutes left. So
15, huh?
Yeah.
Stop. Bala. Can we have the lights off? Yeah. PUG obstruction, I'll try to be brief. PUG obstruction, antenatally, it is the most commonly diagnosed, second most commonly diagnosed problem on an antenatal scan. What is the first most common? Cardiac anomaly. Second, close for second is PUG problems, and most problem the obstetricians have got a very cozy understanding with the adult urologist. So if the adult urologist who first opines on these things, so it's a nice topic. I would like to know the thinking among adult urologists. Now, coming to an antenatal scan. Yeah. Now, what do we look for in an antenatal scan primarily? I think Bala should answer this. Yeah, not only this, to cut you're looking for the dilatation, PCS dilatation or the urinary tract, UTD as we call it now, urinary tract dilatation, whether it is restricted to the pelvis or whether there's the calyceal dilatation. If the calyceal dilatation is there, whether it is a minor dilatation, major dilatation, the medullary thickness, and the most important, the parenchymal thickness. Why have I crossed the ureter there? Because if you see the ureter, it is no longer a PUG obstruction and beyond the purview of the discussion. In any child, even after it is born or any person, if you have do an ultrasound, the most important cut you see is the bladder cut. You look at the bladder, look at the dilatation, ask the sonologist or demand to see a bladder CS. If you don't, you should not be able to see the ureters at the back. If you see a ureters and a bladder cut, that means, you are in for some trouble. There might be a double pathology or missing the problem. It might be a UHN of any cause. Now, when do we do an antenatal scan? The answer is that second and third trimester. And why do we do it then? That's when the urine flow, production and flow is at its maximum. And when is the dilatation significant? That is what we need to know. So, this is a slide which I already had it for nearly 25 years now. So, in the second trimester, any dilatation between 4 to 7 mm, and in the third trimester, 7 to 11 mm. Not much has changed. Even the 2016, this UTD, the on-and classification, they work around these numbers only. So, these numbers are significant. Anything below 7 mm and over 7 mm after 28 weeks is significant. I will come to you guys. So I think to rush, I'm finishing all this because there's nothing to discuss there. Based on this antenatal numbers, you look at the anteroposterior pelvic diameter, APD. It means the measurement of the renal pelvis, anteroposterior diameter taken from one Gilbert space to the other. You will see the fat plane and then you measure it at the level of the renal pedicle, the renal artery pulsation. That is what you do. Here also the latest UTD says it is below 7 mm in 28 weeks and above 7 mm in 28 weeks are low risk A1 antenatal. And then the people have tried to define them as mild, moderate and severe, which is not important actually for us today, given the lack of time. When do we do a post-child? A child has been born with the antenatally diagnosed hydronephrosis or a PCS dilatation. I will ask Professor Edels on that. When would you like to do your first postnatal scan? The obstetrician has called you. Sir, either paper scan first 1 month, 30 days. Excellent, sir. My answer would have been at least after 3 days and ideally at 7 days. The reason, sir, why you want it at 30 days? Yeah, I will get to it because I think you're not able to put it in words. See, the first 1 week of life is a stage of relative dehydration of the child. So it is possible the child has got a mild hydronephrosis, which is not picked up by the ultrasound. So you get a false negative result. And the next scan, God forbid, the patient thinks, Ella nalla irukku, avladhaan வீட்டுக்கு போயாச்சு, Idil Sundar sir சொல்லிட்டாரு, or Vel Murugan சொல்லிட்டாரு, நல்லா இருக்கு, scan சொல்லிட்டாரு, Muralinath sir சொல்லிட்டாரு. They will not come for 1 year or more. You will have a big mass and a bad okay, just because you missed a moderate hydronephrosis during the time of dehydration. So ideally 1 week or even better, I would prefer all patients to be as cool as Edil sir. 4 weeks. No. 1 week, sir. Adorika summa irukka maatanga, sir. They will change the inclination. Yeah, the obstetrician would not, he should know it. Yeah, so when postnatal evaluation, why did I put this word? Is it needed or not? Sometimes you need not do this evaluation. Yeah, if it is less than 4 mm in the 3rd trimester scan, as Madhu says, there is no need to even evaluate such. And then because pregnancy is a time of progesterone excess by the placenta, it is a smooth muscle relaxant. There will be some dilatation everywhere. So you did not, you wait for the first 3 months after the postnatal sex hormone surge is over, then the muscles come back to their normal tone and then you can assess all these things. Okay, no need to be very adventurous in the first 3 months of life. What is significant dilatation? See, the reason on a grade hydronephrosis grading system, I have come to that. So it tells us about how much is significant and it prognosticates or how much will go to surgery and all that. Timing of the first postnatal scan, I said, end of the first week of life. And why? Due to relative dehydration for the first 3 to 5 days of birth can lead to falsely normal scans. Now, this is the essence of the bone and hydronephrosis grading system. 4 grades are there. The grade 1, there is only a pelvic prominence or dilatation. In the second part, you have calyceal dilatation, which is mild. If it is significant dilatation with medullary thinning, then you know that it is grade 3. And grade 4, when there is parenchymal thinning, it is grade 4, along with major calyceal dilatation. Now, Bala, would you like to take judgment calls based on this? Do you use this?
No, we use that because it's similar to the SFU grading, what we
use previously.
Scans and use it postnatal as well, because sort of removes the subjective component, makes the comparisons a little more objective, and for follow-up, what is happening, the grades are increasing.
Suppose you have a grade 3, and how long would you wait?
Not really based on the ultrasound, I will not make a decision. It gives me an indication there could be a significant obstruction. I like to look at the effect of this obstruction on the functional status of the patient.
Excellent. So whether this obstruction is affecting the transit of your drugs, or yeah, fair enough. So, as he said, it helps us to tell us about the follow-up for these cases. When will you do a renal scan? Yes, on and 3, as he said, you do a renal scan, as Bala said, and then in the first 2 grades, maybe you just observe, because it's a minor calyceal dilatation. Wait for a few months and see. I think for lack of time, I will timing of why. Yeah, once you have made confirmed a postnatal scan, when will you do? I will give some suggestions which I do. Whether the panelists agree, it's up. We'll see. If the APD is less than 10 mm, we do it after 6 months. Or as Madhu says, sometimes we can ignore it, less than 10 months. 10 to 20 months, we do it every 2 months. And above 20 mm, it is our ICH protocol that any value of APD greater than 2 centimeters, in a child less than 6 months, invariably they go in for some intervention. Why 6 months? APDs are not valid above 6 months because the kidney, any pressure will, over 6 months, it is taken up by the calyces. Okay, so you will have a significant obstruction without it being reflected on the pelvis. So it's valid only for the first 6 months. So do you agree with this? Obviously, they eventually end up in surgery. IVU, how many of you still do IVUs? We have a renal scan facility, but it is appointment based. So, patients with the volume of cases, we are forced to do an IVU. Any advantage, we'll come to that later. When would, if at all you have to do an IVU, sir, when would you prefer? Okay, see, it's become so obsolete, historical. So if you are going to do an IVU, please do it after the tubules mature to some extent. Don't do it. I don't do it less than 6 weeks, but then you should try not to do it in the first month. But a diuretic renogram, you can actually do it beyond 3 weeks. And the choice of substrate we'll come to later when there is, I think we'll discuss that later. Functional imaging, that is, as you said, IVU, for all its faults, people are not doing IVU because they are not good enough technicians to do it and to do it well and to interpret it well. We have got a wealth of information from IVUs, especially the anatomy. So the best, other than an MRU, which is so difficult to do, it gives us the best anatomical data, especially whether the kidney, if you don't have a good sonologist, who tells me whether the pelvis is facing me or away from me, where do I put the incision, whether the kidney, based on whether you have this crescent sign or the rim sign, we can tell whether it's going to be a salvageable kidney or not. So much of information I get from an IVU. Yeah, especially it gives me indications of, as he said, yeah, radiation. Okay. Now with these new machines, they say it is very little. The radiation is not like the old ones. And radionectar, very, very reliable for functional details. It needs dedicated person. Most of us here, we go by a good ultrasound and a good radionuclide scan. Personally, I have been fortunate in that, I practice only a few 100 meters away from a pediatric sonologist who is available, Murlinat sir. So all my career, I've had somebody who can do a scan within 10 minutes for me, and he gives me all the information I need to go in and operate, whether it's a rotator or not, either way about the ureters, everything. But then, please develop an interest with the sonologist, have a running conversation. As you give him feedback, he or she will improve his reporting for your cases. So that is one take home here.
Some small request, kindly 5 minutes.
Yes, sir. Sorry. No, that is the recommendation. What? Yes, sir. Come to you. No, sir. See, the problem is I want to know what animal I am dealing with, whether there is a problem or not. The first is to confirm the diagnosis. I'm not saying the end of first week. To confirm what has been found out antenatally. You can't, a parent is not going to be at home for 3 months knowing that it has got a ticking time bomb. It assumes, the parent assumes that there is a ticking time bomb inside. So we'll have to give them a diagnosis. It has to have a discharge summary. It has to have a follow-up notes. You'll have to write a diagnosis there. We can't write possible hydronephrosis in today's day and age. We have. I have to know. Curiosity hasn't killed me yet. I don't do, sir. It's been recommended, do it at least 3 days. Huh, sir? 72 hours. It is safer after 72 hours. Don't rely on ultrasounds in the first 3 weeks. That's only recommendations. As I said, the choice of renogram. I have my own choices. Sir, Idil, sir, what would you prefer among the 3? I have put not available. It is available, but not
the sensitive index for
yeah. See, if you see
for the postgraduate, DTPA is GFR dependent. So if you have got a high pressure system in the pelvis, it's going to interfere with the GFR. DTPA you should not. Again, you shouldn't do DTPA where the function is poor. When there is parenchymal thinning, you shouldn't do GFR. Then in those cases, EC studies are better. Among the two substrates between EC and MAC3, I differ from Edel Sundar sir because the EC is slightly better actually, though it is less cheaper because people assume that because it is costlier, it is better. EC has got a better extraction coefficient in the tubules than the MAC3. MAC3 has got 1/3, 30% less extraction coefficient than EC. So EC, the extraction is better. So you have a better reflection of function even in cases where the GFR is affected. So I would prefer EC renogram for that reason. Agree?
Only difference will be that when EC, when we came into the factors, when it also has got some cortical retention. So when you use an EC, you might avoid the need for doing a DNSL later. So we have to do DNSL.
Very good point.
Actually, scores the advantage is that it can be done as early as 2 to 3 weeks afterward. That's the only difference with MAC3 compared to the other two. But if you have bilateral PUJ obstructions, then you need to calculate GFR, then I think DTPA should be the region which
For most of our clinical situations, DTPA is fair enough, except for those large hypotonic pelvis. DTPA is fair enough. It's been much maligned, but it does a good job in it. But most of us outside, we are used to EC renograms. What is a well-tempered renogram? I think I will narrate it here. We don't have time for discussion. The child should be well hydrated compared to IVU where there is a relative dehydration. Here it should be well hydrated. Bladder should be catheterized with an open tube. Bladder should be empty throughout the study. And we give about 5 microcuries per kilogram, a minimum of 1 millicurie. And then supine position. First taken at the supine position and then it is prone to aid drainage. And the gamma camera is positioned to records only from the heart, kidney, ureter, and the bladder. And we usually use a F0 protocol. And we take the region of interest as the entire kidney only. Okay, the subtraction should be very good. Otherwise, you get a bad curve. Or a curve which you shouldn't interpret it. Now, regarding the furosemide timings, sir, I think I'll go through this because we use an F0 protocol. It is because there is a single access is easier. But if you look at maximal diuresis throughout the scan, and F19 should technically be better. So you get throughout the study, they usually take a recording of the gamma camera for 30 minutes or so. Throughout the study, if you want a uniform and good diuresis, an F15 protocol should be there. But the child should be called twice. It's a nuisance. So we do F0 protocol. And for F20, I think the scope is different. I will discuss it sometime else. The curve patterns, the O'Reilly curve. I'll just put a normal curve pattern. This is the vascular phase, the first 5 seconds. And the next 2 to 3 minutes, you have the nephron phase, where it goes through the nephrons, the kidneys. And this is where it comes into the collecting system, the tubules and the pelvis, the next 20 to 30 minutes. So the study is usually over by 30 minutes. That's important. I'll come to the next point. Yeah. If you have now obstructed curve, everybody knows about the light doesn't come down. This is the hypotonic, where you have a dilated system. We don't know whether it is just hypotonic or it is, whether it needs to be operated. You do an F20 protocol. If the whole thing comes down, you're not dealing with a major problem. And delayed decompensation. See, again, this is the type 4, which is a problem which has to be addressed. And I think I discussed this already. The role of an MCU. Would you routinely do MCU, anyone of you, in a case of PUJ? That's a very controversial topic. Unilateral PUJ. Very good. That's one of the answers I put. Reflux, yeah. See, previously we did a study in ICH, long back when I was 90s. So where in routine MCUs were done, we landed in more problems and
UTI because of the MCU rather than the thing. It will pick up. As Madhu says, it is better to do when you have UTI, documented UTI, when there's some hydronephro, I mean ureter seen, hydronephrosis seen at some point. And then when as I said, in a bilateral, you have to do MCU, 3 episodes of UTI, and documenting any UHN in any one ultrasound, either antenatally or postnatally, you have to do one VCU to rule out a reflux. TMSA, TUJO. Okay. As he said, an EC study will give some recoverable cortical function also, but sometimes. Yes. Before, if you're going to planning a very poor thin kidney, rather than doing a pyeloplasty and wasting our time. See, my problems, my experiences, you have a child above 5 years with a large palpable kidney, unlike in an adult. Here, these children behave badly after pyeloplasty, unlike a smaller child with hydronephrosis. In those children, when we know the parenchyma is very thin, as Edil Sundar says, you do a DMSA and you can document that the parent is so low, you get a consent for a nephrectomy at the same time. Intervention. Now, when do you intervene? Now you have diagnosed hydronephrosis. Now, Bala, do you go by just, both Madhu and Bala, do you go by just this fall in function and serial DTPs, or do you operate it?
Not all identically detected hydronephrosis or candidates for immediate surgery.
Correct.
So we wait for the children to earn their surgery. One, we have seen that with the dilatations more than 20 millimeters, the chances of spontaneous resolution is less likely. So you can have a low threshold. But that by per se does not qualify for surgery. Yeah, serial scan showing an increase in the AP diameter associated with cortical thinning could precede a drop in function. So traditionally, we know that a drop in function by more than 10% becomes a candidate for surgical intervention. Symptomatic in the presence of developing a palpable mass can go for infection and for trauma becomes a candidate for surgery. And if infections happen, the PUJ becomes a candidate once you rule out reflux. And of course, in the solitary kidney,
Excellent. What are your thoughts? You agree with Bala?
Yeah, almost.
See, this is how a pediatric surgeon thinks. We are more, as he was talking, we go more by cortical thickness and the progress on an ultrasound, the dilatation on an ultrasound, because we are blessed with very good pediatric sonologists, and all of us use only 2 or 3 throughout the city. So these guys are very good. So when it's about people who don't have access to those sonologists. So we have some criteria for operating the textbooks asset, which I don't much believe in. Split renal function less than 35%, a decrease in split renal function, as Madhu Bala said, by greater than 10% in consecutive renograms, a TF of greater than 20 minutes, and in symptomatic children, as he said, infection, mass, etc. Now, the procedure of choice, all of us do only one thing, a modified Anderson-Heinz straight off and a simple pyeloplasties. I'm not talking of long segments and all that. Simple. Then the approaches, I'll be brief due to lack of time. What we do as pediatric surgeons is a flank approach, extraperitoneal flank approach, and laparoscopic pyeloplasty, and some of us even do a robotic pyeloplasties. Okay, this is the norm of late. So, Murchana sir, don't threaten me, sir. Timing of surgery, well, we will go to the. I personally, and in my unit, we wait till there is no hurry to rush. Bala said that was his first sentence. That is my thinking. It is not that the kidney obstruction is absolute. The kidney is going to burst. The other kidney will take over. You wait and operate at leisure. Handling the ureter, a very thin ureter, which takes in only a 2.5 stent, should be handled with care, because the blood supply is segmented. It is not just about doing the anastomosis, which most of us can do with magnification or without magnification. It's about that anastomosis working, that ureter being patent. We have had cases referred to us where the ureter is lost during a 2-month pyeloplasty or a neonatal pyeloplasty, and it becomes a problem from then on. And most of the cases which are referred to ICH with problem following a primary pyeloplasty, which have been done in children less than 3 months of age. Bear that in mind. It's not that people who are doing newborn pyeloplasties, always land in problems, but then you are risking a lot. So as Bala said, let the child, your word was earn the surgery. Let the child, the ultrasound and the kidney earn that surgery. And 6 months is, you can wait 6 months, nothing happens. Now, when do you go in early? Early pyeloplasty. So when there is a palpable mass causing respiratory distress. So to those who don't deal with pediatrics, infants, especially newborns, are they are abdominal breathers. You've got a large mass which interferes with respiration, better take it up early. Then he mentioned infection, pyonephrosis infections or single kidney. I don't know, for a single kidney, you cannot wait as much. Okay, for the function to deteriorate. Post-op follow-up, following pyeloplasty, what do you do? When do you do the next scan?
3 months later, on ultrasound, 1 year later, another day.
Yeah. The whole thing is that you can do at these 3 months ultrasound. That is what I have also doing. And a renogram 1 year later, and ultrasound 6 monthly. After that, duration of follow-up is 2 years. You have a 2-year problem-free interval at the end. You agree with that. We terminate our follow-up. Though, children always come back to us. There are some other, a lot of clinical scenarios put up. Poorly functioning kidney with grossly dilated pelvis. The options are, I think all of us know this. I will pass that. Recurrent PUJ, again, I pass that, and it's going to be a long discussion. Bilateral PUJ obstruction. Now, you'll have to get an MCU done. Okay. And then which site to operate in a bilateral PUJ obstruction, sir? Excellent, sir. Thank you, sir, for being on my side. This is always a controversy. You agree?
I operate on the list.
Bala? Bala?
We try to salvage the better functioning kidney, but again depends on how bad the 2 kidneys are. Very bad to the better functioning kidney.
No, this discussion can go on for 2 hours. I will ask him then, what about the comp hypertrophy? Will that matter? And then what is the EGFR in such case? There are so many variables here. We can discuss it till the cows come home, but we don't have time. The next speaker is waiting. Nika sir, when will better functioning?
Yeah. Textbook says it is better functioning.
No, that is what I do. I don't know about the textbooks, but symptomatic side and the better functioning kidney. Madhu has a point. What he says is one of our panelists. He says that he operates on the poorly functioning because he probably wants to come back to this side as soon as possible. He wants to salvage as much as the poorly functioning kidney. How you look at it. Then you have to, sir? Okay, correct. So, see, we are talking about infant pyeloplasties and PUJ obstruction, where crossing vessels are not much of a problem. Crossing vessels are children above 5-7 years of age. No, that's why I take it up. Secondary PUJ, again, I will not go to the cause and other things. I will just come to the controversial topic. Which will you, guidance on this? We should ask the adults, adult urologists. Which will you operate? You have a high-grade VUR with the secondary. You have a high-grade VUR, you'll have a corkscrewing at the PU junction. Some of these cases, 30%. You will have a secondary PUJ obstruction. Will you operate on the PUJ? You forget about what Campbell says. What will you do? Will you operate on the PUJ obstruction or on the VUJ? Let me tell you, sir, all of us have differences of opinion on that. So, what will you do? We will correct the reflux or the PUJ obstruction first. Bala?
We are removing the protective effect which the obstruction is giving, protecting the renal parenchyma. By removing that, you are exposing it to the detrimental effect of it.
So at least 3
Second, when you correct the reflex, you can still have a stent and bite some time to tide over the PUJ.
Edelson, you agree? Very rarely, very rarely all of us agree. Now we correct the primary patho. It's a sequence. The secondary PUJ obstruction, the Lapierre-Robin sequence or any of the other sequences we know, that is secondary to the reflux. And as Bala said, it is a protective mechanism of nature to prevent this reflux from damaging the kidney. If you are doing the PUJ obstruction first, you are exposing the kidney, which has been protected so far, to the reflux from below. So many times, it's only about 2 occasions which I can remember where both in ICH where I had to repair the PUJO 2 years after doing the reimplant. In all other cases, it has subsided. The secondary PUJ has subsided following a reimplant. PUJ in a double moiety. I think we will ask the 2 adult urologists. Where is it common, sir? Lower moiety or upper moiety?
Will be obstructed, sir. Lower moiety will be
Yes, sir. If there is going to be a PUJ obstruction, where is it more common? The upper moiety or the lower moiety? Sir, I won't ask them. They know. Ninga, sir. Contrary to what he says, it is more often PUJ obstruction. It is more common in the lower moieties. Okay, the upper moiety in a PUJ obstruction, usually it is not, even the pelvis sometimes is not well formed. So we land up in doing either a PUJ pyeloplasty or anastomosis of the lower pelvis to the upper ureter. Because you can't even do a pyelopelosmy. Classically, the upper moiety in a double moiety will be the pelvis is poorly formed. Unless, of course, it's an obstruction. That is a complete duplication on the problem where this we got Mayer's law there. I'm talking of PUJ obstruction in a double moiety. So I put this up because you people would not be aware of it. It usually is common in the lower moiety. So our surgical options will be doing depending on the function of the moiety. If it's a non-functioning, we do a heminephrectomy, or if it's functioning, a pyeloplasty, a pyelopylostomy, or a pyelurethral. Pyeloplasty is very difficult, in my experience at least. Church. Horseshoe kidney is a big topic. PUJ obstruction is very common in a horseshoe kidney. Why? Because of the course of the ureter has come over the common thing. The isthmus is important, whether the isthmus has got a calyx, a common pelvis, or it is just coarse tissue, fibrous tissue, only an MRU will tell. All that will have to be assessed, whether there's a vascular compromise, whether that has to be addressed, whether the isthmus has to be cut, whether you can do safely a pyeloplasty. And most of the ureterocalicostomies I have done are in a PUJ obstruction in a horseshoe, where I don't want to go and tamper that because I know there might be a problem below the both pelvis are meeting each other. I don't want to touch the pelvis. I do a ureterocalicostomy. Maybe another CME, another day we'll discuss PUJ and horseshoe kidney. That's a one-day topic. Yeah. I think we'll close the discussion.
Thank you, sir. Thank you.
I thank my panelists. Thank you for putting up.
I request Dr. Edilson sir to participate as speaker with a shawl and a book.
So let's thank Dr. Velmugan. It was an extensive discussion, sir. Thank you very much.
Thank you, sir. Without further delay, I kindly request Hemalata madam to felicitate our next Dr. Indrani madam.
I welcome.
Thank you, madam. I took Hemlata madam to the state as speaker.
We welcome Dr. Indrani to give her talk. She is a consultant at yeah.
I request Professor M. G. Radamanikam sir, Dr. Vetrichandra sir, Ilangovan sir. I request our director to facilitate them with the post. Dr. Vetrichandra sir, Gurunath sir, Dr. Chengal Ryan sir, please be on. We'll now proceed to the talk.
Sir, I'll just take only 15 minutes. I know all of you all must be hungry. And I will just finish off one showing my case scenarios. If you want to ask anything, you may interfere and ask us at the end also, no problem. And I'll just tell the points for the PGs, what is to remember, mainly that.
Yes. Yes.
So nuclear medicine in pediatric urology. Change out. So what happens in nuclear medicine? This is what happens. The isotope mainly used is technetium-99M, which is eluted from the molybdenum generator. The pharmaceutical is mainly only 3 things that you have to remember. That is DTPA, EC, and DMSA. YUM you remember for morphology, because I heard someone now telling at 1 month they will do DMSA. It is not DMSA. You should do DTPA. P you remember for physiology. And the difference between DTPA and EC is that the DTPA is a glomerular filtration agent. That's what you have to remember. And EC is a tubular secretion agent. And it is administered intravenously. You have to remember, unlike all other radiology scans, this is an emission scan where the radiation is coming from the patient's body. And it is the radiopharmaceutical distribution is imaged with a gamma camera, which may have a SPECT CT facility as well. So case scenario, the main point is antenatally diagnosed right hydronephrosis. At 4 days old, it is only a 10 millimeter. At 9 months old, it is the renal pelvis is about 21 millimeter. So you have to work upon it. The arrow depicts where the hydronephrosis, it's a posterior view. So you will see the kidney on the other side. So unlike a radiology imaging, scintigraphic imaging, you will have the opposite side. So arrow depicts the right side kidney. You already everything has been discussed. So I'll tell only the points that is to be pondered. The green arrow, it is not descending as it expected in the time activity curve. And you can see the second arrow showing radioactivity in the renal pelvis, which is not building up, which is reducing to certain extent. So these are the things which you have to remember, whether you have to go operating or not operating. Here it is descending. the advantage of the nuclear medicine is the quantitation, that is split function. Unlike any other method where you will get the general idea of both kidney function, the split function is always from the quantitation of the scintigraphy. Here it is left 61 and right is 39. So next image, this is just to show the difference between the PUJO and VUJO, where the obstruction is at the lower end. So you see the entire ureter dilated. So it is a VUJO. Just to point out, the arrow is pointing out where the obstruction is. It's a case scenario 2, antenatally diagnosed left hydronephrosis, dilated renal pelvis and PUJO. Here you see the time activity curve is building up. It is not descending like the previous one. And you can see the same, the pelvic calyceal system stasis in all the pre-void, post-void and delayed images. So it's an obstruction. This is the image, shows the post-operative descending of the same curve. Instead of going up, the red line is going down where the arrow is pointing out. Here it is descending down. Some cases, even after post-pyeloplasty, you can see the tracer building up. You should not think that obstruction is coming again. You have to look for the intrarenal transit time. That is a clinching point. You have to see the intrarenal transit time. If it is normal, don't worry. Just wait for it, do the follow-up. And you can see in the post-void and delayed, the activity is reducing. The case scenario 3, it's an antenatal diagnosis where it says it's normal kidney, whereas the follow-up ultrasound shows that it is a horseshoe kidney. And the image depicts the dilatation of the both sides. You want to know what is the status, what is the functioning status of the both moiety. So here you can see the arrow depicts the isthmus. On in the pre-void, you can see the difference in the tracer stasis. The right moiety shows more tracer stasis than the left moiety, but both are descending. They are not building up. Both are descending. This is the case scenario 4, where recurrent episodes of UTI is there. It's a duplex moiety of the left kidney. And whenever the image is given, it is always better to see the black and white rather than colors because of the blooming effects. So here it is at the age of 2 years of the DMSA. Here's a small left kidney with cold areas. Cold areas means the photon deficient areas. The split function here is the left kidney is only 23 and the right kidney is 77. Then in a present DMSA scan, you can see the cold areas is presenting. So you can do a follow-up with the DMSA and the split function, the left kidney, you can see the small upper moiety, that is 3%, and the lower moiety is 16%, right kidney is 81%. So this does help in differentiating between the function of even the upper and lower moiety. This is a description of the same what we have said. And this is in addition to the DMSA. When you want to see very clearly, you can either do a SPECT or SPECT-CT. SPECT-CT, when you want to see the anatomy very clearly, you can use it. Normally, we tend to avoid it in small children for radiation. And this is the case scenario 5. Where the ultrasound abdomen of a 1-year male child says it's a normal kidneys, but baby has UTI. And in the scintigraphic image of the DMSA, you see the green arrow depicts that there is a reduction in the tracer concentration. But the volume is still not lost. You can see the outer margin very well. So it is a case of inflammation, not scarring. This is a case scenario 6, 8-year-old child, right flank pain, history of blunt trauma. You can see the scattering, that is fracture of the kidney, but the lower moiety is still you are seeing. The fracture portion is still seeing. That means it is still viable. Still you have chance to save it. And you can see the same in the SPECT-CT, the red arrow depicts it. It's a case of horseshoe kidney. It has a functioning isthmus. There was a talk about you have to know whether it is a fibrotic isthmus, where you can do the surgery easily, or whether it is a functioning isthmus. Here it is a very well functioning isthmus. So you have to take care of it. And the SPECT-CT, the green arrow depicts the same. Coming to the direct radionuclide cystogram, there are two types. One is which you do in the radiology. The other one is you do in the Scintigraphy wise. Scintigraphy wise, we don't prefer the indirect one. We always prefer the suprapubic injection and doing a direct radionuclide scintigram. Here, the smallest reflex of tracer into the ureter also can be depicted by the scintigraphy. You can see the little arrow showing the reflex of tracer into the lower third of the ureter. This is just to show the difference between the dilated system and also the reflexes into the pelvic-calyceal system. This is about 3, 4, 5, whatever the difference between the radiology grading and the scintigraphy grading is. The first one is the lower ureter, that is grade 1. 2 is into the pelvic-calyceal system where the dilated ureter is not there. 3, 4, 5 of the radiology goes to the third degree of scintigraphic reflex. So urology is not complete without talking about the testis. Here you can see a 14-year-old child, testicular pain. There is a central cold area. You can see the arrow is showing a rim sign. The already perfusion is not there. Right testis, absent perfusion. Though coming to a 10-year-old child with the testis pain, this very, very beautifully depicts that there is a flow. So there is no infarct. You can do medical treatment. It's an epididymoarthritis. Thank you. Any question, I welcome. For want of time, I finished it fast. You can ask me the questions.
Thank you very much, madam. The wonderful practical approach. The fact end of is.
Yeah, I know. I must be very hungry.
One small doubt. This nuclear for the reflex of the system, will it have any advantage over the conventional inserting system?
So first time when you want to see the anatomy very clearly, always go for a radiological MC. The next time you don't want to put a catheter and insert infection. It is just a simple ultrasound guided suprapubic injection. Then go for the scintigraphic reflex study.
As it is in a torsion testis, the time is very important. Should you subject the patient for radionuclide scan?
Exactly. That, yeah. Yeah. See, when you have a facility like ours, where you have both, when we have a midnight, very, very VVIPs, you have to create a evidence-based medicine treatment there because ultrasound is operator dependent. The increased flow of the peripheral skins, you can still see into the testis. When you have a facility, when it is very important for you to create an evidence, then you go for it. Otherwise, go with whatever is the available modality that you can manage.
Thank you very much. Any questions in the audience before we conclude?
Thank you for inviting me here. I came because of, yeah.
I know you very well. You take at least 1 hour to do that. Actually, she takes 1 hour to do that.
No, already part of my talk is already covered by Dr. Will. So it's okay. He's my classmate.
It's indeed an honor and privilege to have my friend and classmate, Dr. Indrani. She's one of the who is who in Apollo hospitals. She's, I don't know whether she's heading it now or she's number 2, but she's in the nuclear medicine. Indrani?
Same. You see the person.
I know her as Indrani, I'll talk to her as Indrani, that's why. So we know the Indrani before in college days. The same Indrani is there. Same thing goes on. So it's an honor and privilege to have you here, Indrani. And as usual, your topic is very much liked by all my postgraduates. You have a very good positive feedback from all my colleagues and postgraduates. And thank you very much for taking time off to be here on this occasion. And we will have more interactions in future.
Thank you very much for giving me a chance to see all of you. Thank you.
Thank you. Okay.
I thank everyone for coming in good numbers and making this function a very grand success. For the record, I thank our senior professors, our director who has been the keystone of the program, Professor Senguraiser, Dr. Sundar sir, and the hero of today, Professor Prakash sir. Thank you everyone for making this function a grand success. Thank you, sir. Thank you.
Please join us for lunch.
I request everyone to join us for lunch in the department.
Thank you. Thank you all.
Morning,